Hey y'all, Aviva here. Thanks for tuning on to USA Hemp Revival YouTube. I have no idea why I look orange right now. I tried to change some lighting, but I don't know. I had a power outage last night, so I don't know if it changed the color settings, so thanks for bearing with me. When I stand back here, I'm not orange. Okay. That's interesting. Anyway, I'm here to share with you the meeting yesterday, the Blue Ribbon Study Committee on Hemp and Cannabis Policies in Georgia. Now remember, Chairman Dickey, remember when he promised us that we would be included in the committee? Well, don't worry, even though it's kind of frustrating to see that we were not included in this one except during public comment, which is so not fun to just be limited in our expression. There are 3 more meetings, so we're really hopeful that we are going to be some of the featured presenters, some of the experts in cannabis knowledge, how everything comes from CBG, how there have been absolutely many studies to show the positivity of its effects in the legal states. Oh look, normal settings now. I don't know how that happens. Share this with you. Please write your comments on how you're feeling about this. You know, even though some of these folks do have some valid points, they do seem to be a bit exaggerated in some cases and ignorant of the fact that cannabis is such an incredible plant. And I just want to say, that's better. I make an outstanding agreement to honor and respect cannabis as a plant for food, free to be planted, harvested, and processed by all. Kitty cat, you're not going to get out by throwing yourself against the door. But anyway, that's how some of us feel, like we're throwing ourselves against the wall. So, with no further ado, here is the meeting from Tuesday.
Good afternoon, everyone. Committee members, good afternoon. I'm Representative Mark Newton. I'm going to call this meeting to order of the Blue Ribbon Study Committee on Georgia's medical marijuana or cannabis policies, along with our hemp policies. I want to welcome everyone who's attending in person, those of you who are attending by either Zoom or the video broadcast. I do want to begin and thank the speaker for recognizing that while we try to get everything done in a 40-day session with some dedicated committee meetings, there are many policies that require a much more in-depth study, and that we do what we call the off-season, which is the rest of the year for those of us in the 3-month part-time legislator positions that are on this committee. I want to thank all the members of the committee who agreed to be on this after the speaker nominated them, both legislative as well as our Department of Ag ex officio members, as well as our citizen members as well, who are from the community, who are interested in, involved in, or care much about one of these policies. I do want to start off before we introduce the committee members. I do want to just point out, and I know there's a lot of people here and a lot of people on the committee, there is some blurring in this committee, which happens because of the fact that we're looking at really 2 different policies. They are joined by a particular chemical substance, a particular I wondered how long it would take before, but they're joined by some chemical, but they're really 2 different sets of policies. One is something since 2015 we've had in Georgia dealing with medical cannabis and the medical use under a physician's direction, with some regulation and some policies that frankly took many years to get to where we are today. And one of the things we want to look at when it regards medical cannabis is how can we make that program better, and how can we ensure it's taking care of people, it's not inappropriately being used, but is appropriately being used. So medical cannabis or medical marijuana is one area of this Blue Ribbon Commission that we're assigned with. And second area is hemp policies. That's more related to some things that have happened since the federal law changed. While this is still THC, which is the active ingredient in both groups, while that's similar and still a Schedule 1, at the same time it's allowed in a very small percentage through federal hemp policies. Many states have been trying to deal with how do we manage this in a safe way, in a way that makes sure there's not inadvertent toxicity or poisonings. By the way, I am a medical doctor for a day job in addition to this part-time job. So those are the 2 areas: hemp policies and medical cannabis policies. And that's where this commission, Blue Ribbon Commission, is going to have to do a good job of separating. We may hear from one individual talking mostly about hemp policy. We may hear from two others that are talking about medical cannabis and patients and a doctor-patient relationship, for example. So we do want to recognize that we're dealing with two topics, but we're a very experienced committee and have some wonderful members. And I would like to go on and start now. If we can start on the far end, just briefly introduce yourself, maybe where you're from, and anything else you need to tell us.
David Clark, state rep for District 100. I represent parts of the northern part of Gwinnett, part of Hall County, and Forsyth. And glad to be on this committee. And been here, it's my 11th year. So love serving and look forward to digging into this over the next 5 committee hearings.
Thanks, sir.
My name is Wesley Dunn. I'm a citizen member of the committee. I am a former legislator, served 10 years, a long time ago. I was telling my colleagues up here today, it's been 33 years since I've been on this side of the table. And I'm very honored and privileged to have been selected for this. We've been following this issue, hemp in Washington and Georgia since 2010 and been following the medical cannabis since 2015. My wife and I got in this because of meeting some patients, and our focus has always been on trying to help people.
Thank you, sir. One of our citizen members. Thank you, sir. Another legislator, Chairman.
Thank you, Representative Robert Dickey, from representing 4 counties right in the middle of Georgia. Chairman of the House Ag Committee, which we've seen some of this legislation flow through from time to time. So looking forward to going deeper with it. And thank you for setting that up a minute ago. Very well done, Mr. Chairman. So glad to be here.
Thank you, sir. And thank you for your work in agriculture. Representative Ridley.
Representative Jordan Ridley, District 22, Southwest Cherokee, North Cobb, and Lake Allatoona, and glad to be here today.
Thank you, sir. Representative Cox.
Yeah, Representative Brent Cox, District 28, which is Northeast Forsyth and West Hall. Glad to be here, and I have a recommendation that Chairman Dickey will bring his peach ice cream to the future meetings. That would be my only ask.
Is that in the form of a motion? No, we'll just acclamation, I believe.
I second it. Yeah.
Dr. Fowler.
I'm Robin Fowler. I'm a citizen appointee. I'm a local anesthesiologist. I specialize in pain management, and I'm also the founder of one of the licensed medical cannabis companies.
Thank you for being a part, sir. Would you go on? Is that you? Okay. Go ahead.
Al Williams, I represent District 168, Liberty County, and to my distinguished friend and chairman, Dr. Newton, I take exception to the term part-time. Nobody believes that at my house, but I'm glad to be here, especially serving with all of this expertise here. And I just want to let you know, when I'm not working here full-time, I'm planning on getting a job part-time picking peaches for Robert Dickey.
You can help him carry the ice cream. Thank you. Commissioner, glad to have you here. Please.
Good to be here, Dr. Newton. Tyler Harper, Commissioner of Agriculture for the great state of Georgia. And our agency has the distinct responsibility of overseeing the hemp program. And so we're honored to be a part of this conversation and look forward to the work of this particular committee, and hopefully we'll have be making recommendations for the right policies for our state for next session. But glad to be here.
Thank you for being here, Commissioner. And Ms. Russell.
I'm Catherine Russell, the Director of Policy at the Georgia Department of Agriculture.
And our senior member, Chairman Powell, Regulated Industries. Sir,
be careful when you say something about being seniors. But
couple of years ago,
I represent the 33rd District, which would be Madison, Franklin, and Hart County. I currently chair the Regulated Industries Committee, that we get a chance to dabble with everything that needs to be regulated. Originally, in this particular issue, I was an early supporter of medical cannabis, having always said that anything that God lets grow natural is better than something made in a laboratory somewhere. been very active. We had some of the CDB legislation in front of us this past year. And I'm also, probably my most noteworthy adventure is that I'm Al Williams, director of his social calendar.
It's a busy one. Well, thank you all
So
for
we're
your
just
time.
a little bit into this, and I just wanted to remind you to please subscribe to the USA Hemp Revival channel if you haven't. Please like this video, please comment, because all of that helps to create algorithms towards this awareness. All right, let's keep watching.
Cannabis, having always said that anything that God lets grow natural is better than something made in a laboratory somewhere.
Well, thank you all for your time. And as my friend Representative Williams points out, this is it's allegedly a part-time job, at least when you ran for it. But thank you for committing to all this. Once again, we do have these two related topics. I am going to ask all the committee members to see if we can, if you're taking notes or keeping things in a file, you may want to keep them in two separate ones because of the medical cannabis and the hemp-related products. We are going to get started today with a couple of our departments who are directly related. There's the Department of Public Health, which largely oversees our medical cannabis policies. But in addition, the Department of Agriculture has currently been tasked with overseeing our hemp-related policies in Georgia. And I'm going to let them begin. If you want to go present at the microphone right there, Ms. Russell, we'll get started though with hemp-related compounds, let's just say, that's more newer, and maybe you can give us a little bit of background on. Would you like to sit down? That's fine. Please do. Please do. Okay, certainly. Yes. There's a microphone right there, and you have your presentation, which our members do have it in your folder as well. So we'll go on and get started. Just quickly reintroduce your current role and then take off.
Okay. Good afternoon. My name is Catherine Russell. I'm the Director of Policy and Policy Counsel to the Commissioner of Agriculture here in Georgia. Some of you guys may recognize me from my days in the Senate as a staffer. So I've been around for a little bit here. And then I'm also joined by Bruce.
Hey, I'm Bruce Stanford. I'm Deputy Director of Law Enforcement for the Department of Agriculture, and I oversee our hemp enforcement.
So I'm going to try to move through some material pretty quickly. I apologize for the 35 slides that you already have in front of you, but I felt like there were just some kind of basic things that we could maybe get out of the way just to make the conversation a little bit easier. Let's see. In this presentation, we're going to go over a couple of things. First being terms. I found that it's really challenging sometimes to talk to people about cannabis. Because people use different words to mean the same thing. This also varies from state to state and sometimes at the federal level and the state level. I'll talk to you a little bit about the plant, the legal framework that we're currently operating under, hemp and marijuana economies, how those are separate and where they might overlap, regulations, structures that we have at GDA, and then Bruce is going to give us a law enforcement update. Okay, so what is the fuss about? This guy right here, this is cannabis, oftentimes referred to as cannabis sativa, and almost all legal documents referred to as cannabis sativa L. When you look at this plant, you cannot tell just by looking at it if this is considered hemp or marijuana. Now, we think this is probably a girl because there are lots of big flowers and she's pretty. But that's about what you can tell if you just kind of come across them. I am going to preface some of my presentation by telling you that a lot of this information are not my own ideas, that I have gathered them from other sources. I have not cited them on the PowerPoint just to save space, but if anybody on the committee would like cites, I'm happy to provide those. Okay. Terminology. We'll start with this because this is something that's kind of unique to Georgia. By and large, when you work with governments or governing bodies, they will use this framework, which you'll see that cannabis is the umbrella term. That's because it's actually the genus of the plant. Okay, so I've got like the botanical classifications here. You can see that when we go further and further down, we get to the genus, which is Cannabis sativa. This will be for hemp and marijuana. So it is the same plant, but we separate it. And the way that we separate it is by legal definitions, which are the two categories within the larger cannabis box. We separate them into hemp and marijuana. And the way that we do that is that we look currently in the state of Georgia, we look at one compound, which is the Delta 9 THC. And that one, the measurement of that one compound will determine whether or not it falls into the category of hemp or it falls into the category of cannabis, or I'm sorry, marijuana. So if you were to look at this sample profile that I've provided, you'll see that there is a spike around about the middle of the profile, and it lists a number for D9 THC. And you'll see, I think it's like 4 point something. It's definitely above 0.3%. So within the category of what is considered marijuana, you have legal and illegal sources. So some states, like in Georgia, we've decided that there is a legal route to consume and then there is an illegal route to consume. What's challenging is that our terms in Georgia, we use cannabis in about 3 different places. We use it to refer to the plant as a whole. We use it to refer to our marijuana program, and then we also use it to refer to low THC oil. So just something to keep in consideration as we continue to have a conversation here. Okay, understanding the plant. For those of us that are plant lovers, even though I kill them, which is not on purpose, but I do like to buy them and keep them in my home. I think people will say, oh, this one's unique, this one's exceptional. But having studied this plant a little bit, it really is a very powerful and a very unique plant. A couple of classifications about it. It is considered a dioecious plant, which means that it's either pollen producing or ovule producing. So they're basically gendered plants. You have some that are female and some that are male. The female are the most interesting because those are the ones that actually have the flower buds. The plant also contains cannabinoids, terpenes, and terpenoids. And that matters. Those usually occur on the trichomes. So this is an up close picture of trichomes. So they are these unicellular or multicellular appendages. They extend off of the plant. They're pretty sticky.
There will be a quiz.
Okay. And they occur, it's not actually the flower that people are interested in, it's more what's inside the trichomes. And these occur at the same time at the flowering stage. So when you hear people talk about flavors, smells, they're referring to these components that you'll find in the trichomes. So within those trichomes, you'll have cannabinoids, which we talk about a whole lot. Cannabinoids are chemical compounds found in the cannabis plant. Predominantly, you will find CBD and THC. There are over 113 classified or identified as phytocannabinoids, but they all have the 21 carbon atom ring structure. Beyond that, there are variants and synthetically derived cannabinoids, which are innumerable, because people can manipulate to create a vast number. I've got a couple of examples of cannabinoids listed here. You will more than likely hear these cannabinoids identified by different speakers. I would say to pay attention to CBD, THC, Delta 8, Delta 9, Delta 10, HHC, THCO, THCP. This is the molecular structure of CBD. This can be easily modified to create other compounds. So one way that you can see this altered, you can create THCP from CBD. THCP does not occur naturally within the plant. And one of the reasons that it is concerning to some folks is that it purportedly binds to the C1 receptors, the CB1 receptors in the brain with about 33% times the efficacy of other THCs. So it's kind of a super potent cannabinoid. I'm not going to get into what CB1 and CB2 receptors are. They're in the body. They're part of the endocannabinoid system, which I'm sure someone else will be happy to talk about, but I am trying to keep it brief. So I kind of alluded to this in the last slide. We're essentially looking at a situation where we have this plant with these properties. We're pretty much in a chemistry game at this point. There are all kinds of products that can be made by taking your kind of benign, non-suspect CBD components, but also there are other sources. So one of the things that a lot of people aren't aware of, there's a company out of Florida called Peels. They create their CBD from citrus, from orange peels. So they don't even use, like you can go and you can regulate cannabis all day long, but if you can source your CBD from somewhere else, then the laws don't actually cover that. So the great thing about this emerging industry is that there are entrepreneurs involved and very much touches on the American spirit, but it also makes it very fast moving. In addition to cannabinoids, there are terpenes. These are particularly sticky and they give plants their aromatic and flavor characteristics. Oh, goodness.
Can you define aromatic? We need to walk on the belt line.
What did the Supreme Court? I know it when I see it. I know it when I smell it.
All right, that's the aromatic I'm talking about, right?
Yes.
Terpenes.
Yes.
Okay. Thank you for.
Well, And so also what you can consider, so my slide didn't quite turn out the way I'd wanted it to here. You may hear people come testify about the entourage effect. And this happens when a consumer ingests cannabinoids, terpenes, and terpenoids all at the same time. And this purportedly has a different effect than if you were to isolate and only consume portions. I say purportedly because these are not my opinions or my experiences. Okay, we'll jump now to an overview of the legal framework, unless there are questions.
Please proceed.
Okay. Okay, just a disclaimer here. I am an attorney, but I'm not giving legal advice. I work for the commissioner, and so we're just having a chat. Just kind of a quick overview of preemption and the supremacy clause, because we do deal with a lot of this with hemp and marijuana. So, we'll start with the law of the land, the United States Constitution being the most preemptive. Then beyond that, we'll have federal law and then federal rules tucked right up underneath the state constitution and state law tucked right up underneath that. And then lastly, the state rules and regulations, which is where GDA falls. If you were to look in the federal law, that's where you'll find definitions for marijuana. You'll also find the Schedule I designation for marijuana. Additionally, you'll find the definition of hemp, which is where they basically go in and they distinguish hemp from marijuana by excluding it to the definition there of a controlled substance. Federal rules, but not federal law, will offer other guidance. Right now, we have to follow the federal rules, and we have a hemp farming plan that we were able to get approved by USDA many years ago. We cannot drop below those legal requirements. And then further, they provide testing, conversion rates, other guidance that are required to be followed by states. So you will see some of those federal rules kind of trickle down and work their way in. In Georgia, we've had the HOPE Act, and we've also had the Hemp Farming Act. And these are the two main sources of information on cannabis as a whole in our state. And then we have just a couple of more fun things that don't actually fall within any structure. So a couple of other things that we may want to consider, some other pieces of information from the feds. There was a letter written, I think this is back in 2023, where they recognize Delta 9 THCO and Delta 8 THCO as not occurring naturally and being obtained synthetically, and therefore not fall under the definition of hemp. Now, there's not anything in any law or code that recognizes if something is synthetically derived or not, but we have seen the federal government take note of it in some of this correspondence that's been shared. Additionally, the DEA sent out letters a couple of years ago. You guys may remember many of these went to our pharmacies, where they made it clear that a DEA registered pharmacy could not dispense a controlled substance if it were Schedule 1, which complicates things for some of our pharmacists here. So we have seen further quasi-clarification from the federal government there, at least from the DEA. Drop down from that, and we've had a couple of Georgia courts, a couple of cases that have been really interesting. One of the ones here in our state, this was a case about products that were seized by the authorities. Our courts have recognized that the Delta 9 content alone is what you were to consider whether or not something is a hemp product, and they do not consider synthetic, the derivation or the composition at all. So just a slightly muddy water there. Okay, understanding the hemp and marijuana economies. And Mr. Chairman, if you would like for me to skip over this, I can, or I was just trying to set up kind of a quick comparison.
No, go ahead on just
Okay.
briefly, because those are a little important for us to see them in the graph form that you've done. I think it's helpful if you will go down that pretty quickly, although I know with the synthetics and the 8s, 9s, 10s, THC versions, there is or Delta 8, Delta 9, Delta 10. Do you know the relative potency of 8 versus 9, 9 versus 10, 8 versus 10, or maybe somebody can speak to that later.
I am not aware of any studies that do a direct comparison of the effects of 8.
And when I say effects, I guess I mean psychoactive effects, the high part.
And I think that can be altered also by what other cannabinoids may be present. So I think, but I do not have an answer for you.
Okay,
And
thank you.
The short answer is I don't
Go
have an
ahead with your
answer.
comparison. It's helpful.
So, So when we're comparing, okay, what do we have going on here in Georgia? We have this low THC oil program that's been in existence. I think it predates a lot of what we've seen with the hemp products and the activity here with hemp. So first, when you consider low THC oil, this can be marijuana because it can have Delta 9 content. I just abbreviate it for D9 here, over 0.3%. Now, hemp products cannot. They must be 0.3% or less. The low THC oil program is administered in Georgia by the GAMCC and by DPH. The consumable hemp program is administered by the Georgia Department of Agriculture and then our law enforcement partners. And I'll actually let Bruce speak to that a little bit later.
So did you go down your list of low THC oil, the current situation in Georgia? I know DPH will touch on that too, but did you go down your list all the way on
There are just a couple more bullets.
Oh, sorry, go ahead.
THC oil requires that you have a medical diagnosis. There've been limited licenses, a competitive award process, and lawsuits, versus if you were to look at the hemp programs, you've got a simple registration requirement, no medical conditions. Everything is legal under federal and Georgia law. If we were to look at the low THC program, it is legal under Georgia law. Quickly, I'll go through the GDA regulations. You guys may remember that we passed you passed SB 494, and I talked about it a lot. And we essentially went from a situation where the Department of Agriculture was overseeing the growers and the processors, but anything beyond that, the manufacturer, the distribution, the sales, any kind of lab tests was not governed by or overseen by the department. And we've expanded that, essentially resulting in a 5-tier system where we keep track of where the products are within the state. We recognize that there was a problem with the hemp products that were being sold. So some of the solutions that we went ahead and identified there were prohibition to sales to people under 21, requirement for there to be warning labels, testing and truthful labeling requirements, banning lookalikes, a central registration, shared enforcement authority, and milligram caps.
Can I question, were all those regulatory determined, or were those in Georgia code directing each of those?
So there are.
That's okay. We'll get back. We'll get back to it. Go ahead with law enforcement.
Right. So I think
You had mentioned your hierarchy earlier with the U.S. Constitution and state, and then eventually down there was
sure
department
so,
rules and regs. Are those?
So
Are those, is that list
everything-
of things under 21, lookalike, central registration, are those department rules and regs, or are
Yes.
those in Georgia code?
They are all department rules and regs.
Okay, thank you.
And then the first components are also in code.
Okay, thank you. Proceed.
Let's stop and let Bruce talk now.
Thank you, sir. Just reintroduce yourself briefly to us. And
Mr.
We are
Chairman,
on a
committee
time
members,
schedule.
thank y'all for
Thank you.
the opportunity. My name is Bruce Stanford. I'm Deputy Director of Law Enforcement for the Department of Ag. And I'm also tasked with overseeing our hemp program. And I just kind of want to give you a lay of the land of the market participants right now, how hemp gets to market, the checks and balances that are in place, how we come in and how we take a look at that and follow up. And then also data that we collect so that we can best use our resources going ahead. So right now there's almost 7,000 market participants, license holders in the state. I always use the word approximately because every day we have between 50 and 60 license applications pending. New folks are applying for licenses, whether they be, most of them are retail are the biggest ones we see. We have 48 growers currently in the state of Georgia. Right now, I cannot give you planning information for this year because it's all due to be reported tomorrow. So we'll have more of it when everybody files a planning report. But if y'all need that in the future, I can get that to you. We have 9 processors, licensed processing facilities that are in the state. We have about 10 manufacturers. We have more manufacturers than that. We have about 10 that are currently licensed. We have 170-ish wholesalers, and those are in different varieties. We have some wholesalers here in Atlanta that sell to the convenience stores and what have you, and their places are really big stores. They do a lot of tobacco and hemp products and smoking accessories from the same building. We'll see those, and then we see a lot smaller on-demand type wholesalers as well. And then we have our retail market. And so the retail market largely consists of smoke and vape shops and convenience stores. So that's currently who we're dealing with. We have 13 or 14 registered labs. So in order to sell products in the state, they have to be tested, but they can only be tested by a lab that's licensed through the department. And that's just a little check valve that we have to ensure the labs have the certification standards that they need to have, that they have their DEA licenses to handle the products in the event that it's not hemp, so on and so forth. So the big question is, how does a product get to market, and how do we safeguard that product? In a perfect world, is grown on a farm, is tested before it's harvested to make sure that it's legal. If it's not, then we have a disposal methods and we handle that. Once it's harvested, it goes to a processor. Once it's processed, it's again tested to make sure that it is a legal hemp product. Then that's usually a distillate or a resin or a rosin, something along those lines. And then it goes to a manufacturer, and they'll use it in manufacturing their products, whether it's gummies or vapes or what have you. Once the product is manufactured in its final form, it is once again tested. And so we have standards. So if you produce 5,000 of a particular variety or flavor or what have you, then we have set numbers of samples that have to be submitted for testing in that final version. So if you use the same distillate, but it goes to a different flavor, then that's a different test for that one. And that's a safeguard for the consumer, right? Because the consumer doesn't know what happens between the distillate and the making of the different flavors. And so that's why that is in there. Then the product goes to a wholesaler. The wholesaler does not have to test the product, but they do have to ensure that the product is legal by accessing the certificate of analysis that was last performed, which would have been the one that the manufacturer performed. And then the same thing for the retailer. When they get the product, they have to make sure that the product is legal as far as the COA, that it's packaged properly, is tamper evident, child resistant, has the Georgia warning label on it, has a COA, and all those types of things. So that's how a product gets to market. Talking about the inspection process, we started out working largely on complaints, which made our life easy because we did what we're looking for is voluntary compliance. It's just like with any other law. That's all we want. And we would get a lot of complaints, but it was from people in the industry because, you know, if you're running a store and you tighten up and you do everything like you're supposed to, but the guy that's 3 blocks down the street is still selling illegal products, or the folks that just want to get high, that's where they're going to go. So that helped us a lot as far as finding some of the bad actors, and getting people in place. So we work the state geographically. We map how we go out. We work off the complaints. We have civilian inspectors that go out. We use a cloud-based online reporting system, and it has a dashboard where we can collect all the data. To date, as of this morning, we have done 918 inspections. We have about a 46% non-compliance rate, which is really high, but a lot of that is around the COAs and the packaging of the products. We're having a hard time, and we're actually working with the manufacturers and with the wholesalers to get them in line. When we first started, there never was a grace period, but we had an educational period where we talked to folks in the market. Because look, if you want to be in the hemp industry, we want you to be in the hemp industry. And we have been, and we will continue to be a resource for everyone. But we started educating on this is how you do things and this is how you do things. And now the education period is kind of worn off. So we've been going out and we've been doing some some enforcement. We do a lot of under 21 operations. We try to do those a couple times a month, and that's always we have yet to go out and not make purchases to a person that's under 21. So we're doing that. We've also started issuing citations on packaging that's improper, not having the proper COAs, in addition to our administrative stuff. So when the civilian inspector goes out, they'll issue a cease and desist order. They'll issue a notice of violation, and then they'll send that violation over to the law enforcement division. And we'll take a look at it and we'll follow up. And if the problem still exists after that administrative action has been taken, then we'll take action as far as criminal charges and go forth that way. And so as far as the data that we collect, we want to see what the violations are, what we need to target on and how to do that. One of the things that's been really helpful is working with the wholesalers, because a lot of the product that goes to retail, it comes through these big wholesale warehouses. And so if we can get our partners in the wholesale industry to get on board and police their product, that'll reap benefits down the line. Another thing that we do that's kind of I guess you could call it a force multiplier. So we have a lot of food safety inspectors, right, that go to all the convenience stores. We train them up. And so they don't conduct an inspection per se, but they do look at the products. And when they see things that are out of compliance or that they think we need to look at, we have a mechanism in place where they can notify us, and we'll have an inspector go and follow up on that as well. So that's really been good. We've had really good partnerships with law enforcement agencies across the state, going and talking to them, working with some departments on the enforcement side. Like I said, we're looking for voluntary compliance. So if we don't have to do any more enforcement, I'm good with that. That would be okay with me. But if not, then we'll take whatever necessary steps that we need to take. I appreciate it.
Thank you for you and your team. Do you have some closing next time comments? Did you have? Please go ahead.
I did have one more slide. We certainly appreciate the time to speak before the committee. And if we're able to continue the conversation, there are some things that we would like to bring forward. Particularly, we would like to address some of the emerging topics that we see coming in this industry. There's been significant discussion about taxing. Hemp beverages have really taken off lately. There's been significant conversations about different milligram limits. A lot of people are serving hemp, which I think is going to be kind of the next real area that we might need to look at. And then also there's been significant conversation about restricting or banning some cannabinoids. Further, we'd like to talk about how some of our states in the country are doing things that are we consider to be useful and some not so useful. So particularly, we're probably going to hit on Tennessee, Texas, California, and Florida, and then also discuss some of the proposed legislation that Congress has been looking at. And so we would like to have the opportunity to say kind of what we would like to see happen or what we would like to recommend, but felt like it was important for us to all kind of start on the basics today.
Well, thank you for your testimony. We are on a tight time schedule, but we do have a question or two. I had one question. You had mentioned a figure of maybe 46% non-compliance. Obviously, that's as you start a program, people have to get used to it. You mentioned going to the wholesalers. One question, does testing of the end product, does that ensure that it still meets the definition of no more than 0.3% Delta 9, or does that include the other synthetics, which of course we're always in a different area. We're always fighting them with fentanyl, changing the chemistry a little bit, and then it's no longer illegal until we pass a new law in Georgia the next year. Is your end product testing making sure that a 16-ounce beverage is no more than 0.3% Delta 9 or THC or?
Yes, sir. So in the regulations, it does, to answer your question. Yes, in the regulations, we specify exactly which cannabinoids must be tested for. And I think
There'll be others in there that you aren't testing for that are synthetic and that are causing a.
there could be, yes, sir.
Okay, so that's one of that probably could be added to these emerging topics.
Certainly, we are currently testing for a lot of other cannabinoids beyond Delta 9, and that's required to be in the COA. And I can certainly provide a list of those. We are not testing for everything. I've had some conversation with people that run labs.
Step ahead.
And you can, right, there's some things that are very hard to find, if there's even a verifiable way to test. But currently we have a fairly robust testing regimen for now, everything on there isn't spoken to in the law, or even some of our regulations, but having consumers know what they're putting in their body is something that the Georgia Department of Agriculture takes very seriously.
Thank you. You do in so many areas. We do have a few questions from members. Representative Williams, you were first.
Thank you, Mr. Chairman. The question I have is for you, Bruce. A couple of questions. You said there's 7,000 locations or 7,000 distributors, or how did you put that?
There's about 7,000 license holders.
License holders.
Yes, sir. There's probably 6,400, I think, retail locations.
Yeah, follow up, please, Mr. Chairman. You had a 46% non-compliance. I know that startup's built in there too, but I know you're wearing that hog smoker and you got a badge. So how many cases have you made to date because of lack of compliance, or have you had to make any arrests? What are you seeing? Warnings, et cetera.
So I don't know the number of cases that we've made offhand. It's been quite a few.
Okay.
We have some that are still up under investigation, because sometimes a violation or what we observe in a store will lead us a little more away from just the hemp program. And so that takes some investigation. So we've got a few cases that are under investigation as well.
Do you have the resources? 6,000, so that's a lot of people. Commissioners here, I want to make sure, do you have the resources to properly police this? And are you going to do many cases in Genoa, Alaska? Because I'm looking at your outfit and I got hot looking at you.
The cotton breeds well.
Okay.
Thank you, sir.
So, no, sir, we could always use more help, and more resources. We are doing a lot of work. Our team does a fantastic job, getting out, and we have great leadership and support. But in short, yes, sir, we could use some help.
Thank you. We'll remind everybody we do have to start on medical cannabis shortly. So, but go ahead, Chairman Dickey.
Very quickly, thank you, Mr. Chairman. I'm trying to, the retail products, do they have to originate being manufactured in the state of Georgia, or all products flow through the Georgia wholesalers? Just give you a little bit of information about that.
So crossing state lines is fine.
It is fine. So there's a lot of manufacturers in other states,
Right.
and they'll ship to a wholesaler here. There are some manufacturers that will ship directly to a retailer here.
Okay, that's
And in some instances, consumers can buy online.
yeah. Okay.
And so that presents its own unique set of challenges.
Now, all of those products, though, do you have to meet the same requirements, the same safety requirements, regardless of where they come from?
Representative Cox.
Yeah, two questions. 900 plus inspections, that was roughly, did you say 916 or something? 918. Those inspections were specifically in the holder market. Were they in the grower? Like, where were those inspections done?
So those inspections have been done in the retail and the wholesale, is where they have been done. We've done grower inspections, but it's not reported in that particular system. It's reported in a different system. So that's where that is at. And the manufacturers, we've probably done a handful of manufacturers inspections. And for clarity, if if an individual buys a 5,000 count tub of gummies and gets it in bulk and then repackages it in their store with their branded packaging and so forth, under the definitions, that's considered manufacturing. So that can be a little misleading because initially you think of manufacturing as, you know, like Charlie and the Chocolate Factory, but it's not exactly always like that.
Okay. Follow up.
But
Okay. So there's a non-compliance form, which would be great if we were able to see something like what that form looks like or.
Thank you again. I just wanted to jump on here to say thank you again for watching this. It's a lot of information. There are some timestamps listed below if you want to jump around and just go to the public testimony part or just go to a specific speaker. And I also want to say, if you are loving this content and really want to contribute some donations towards everything that we're doing, you can go to usahemprevival.com and you will find the donation link there. Our goal, we appreciate you so much. And also just spreading the awareness is such a great thing. So thank you for doing that.
So there's a non-compliance form, which would be great if we were able to see something like what that form looks like or however y'all do that. But my question would be, of the 46%, if it's in the manufacturer wholesale world, do we know what percentage is not from the state of Georgia?
the products,
The non-compliance, the 46% that's non-compliant. After Chairman Dickey asked that question, it made me wonder how much of the non-compliance is from stuff coming from outside our state.
a lot.
Okay.
I mean,
And you can get clarity on that at some
Yeah, and
point,
the-
but
because-
that may be a.
We might need to follow up at the next meeting in
Sure.
August. It might,
Yeah, thank you.
Thank you.
That's all.
that non-compliance would cover everything from the sale of raw flour to not having under 21 signage posted. It covers a lot of things. It's not just the product, but that's what we see the most.
Okay, yeah, that form would be great. Thanks.
And Commissioner.
Thank you, Mr. Chairman. I just wanted to make a couple of points of clarification just for the committees. So we've only been, obviously, this has only been in effect since October 1st. So we're not even a year into our enforcement or inspections or the work that our team has been doing, really and truly, to Bruce's point. It's really only been in the last 6 months or so, because we did a lot of work with the industry early on in ensuring that they were educated and understood what the new law was. So really and truly, it's really been in the last 6 months. The numbers that Bruce has been sharing have really been over the last 6-7 months or so. Just so y'all know. So we have been doing a lot of work. So that's not 900 inspections in a 3-year time frame is what I'm trying to make sure that y'all are clear of. I think the other thing is, I know there's been a lot of talk about testing. We test for total THC concentration, total Delta 9, which means Delta 9 THC and THCA converted. And so that is per federal law. Just to make sure that that's clear, so everybody knows that it's a little more than just Delta 9, if that makes sense. And we can go into more clarification about that. And my good friend, we could always use help. Thanks to the General Assembly, y'all did give us a little help this past session. That we're working to bring those folks online now. We appreciate it. But I just wanted to clarify those few things and appreciate y'all's help.
Thank you, sir. One last question. Mr. Dunn.
Catherine, I'm very much interested in where you got next time, and I'm not going to ask any questions about that. I had some notes over here, so I'll wait till your presentation on that. But I would like to hear something next time about industrial hemp. In my opinion, that's something we're missing out on from the standpoint of our farmers and growers. We haven't had many processors in the state, so a lot of the retail products are coming from out of state. But I think the industrial hemp side gives our local folks an opportunity to participate in the industry more than they have so far. So please put that on the schedule.
I will be happy to do that. I have lots of thoughts.
Well, thank you. You did have emerging topics on there, so we may invite you back for another chat. not legally binding, but I appreciate y'all's efforts today. Thank you for being here, and we are going to move forward.
Thank you.
As I mentioned, we will have to shift gears quite often on this Blue Ribbon Commission. I'm going to go on and ask our Department of Public Health to begin. Come on up either to the table or podium, whichever you're more comfortable with. Let's see. Is it Graham Segrist, are you going to go first? Or okay, thank you. Y'all more comfortable there? Please, thank you for being here. And if you will briefly introduce yourself as you get started, and thank you. I think we have here's the handout with the red on it. So we'll get started. Thank you for both for being here today.
Absolutely. Thank you so much for having us. My name is Graham Segrist. I'm the Government Affairs Director for the Department of Public Health.
Excuse me, I'm Jason Jones, the Executive Director for the Georgia Medical Board.
Awesome.
Thank you both for being here. Go ahead and I guess you got a slide program there. So we'll proceed.
Yes, sir. So we're just going to
by the way, we are in a little time crunch, so 1 1/4 speed would be good.
Sounds good. We'll keep it brief and to the point here. So I'm going to give you guys a very brief overview of the low THC oil program. I know most of y'all were here when it was when the bill was passed in 2015. Can you hit that for me? Thank you. So that was Haley's HOPE Act, which is House Bill 1, 2015. It gave DPH the duty of managing the low THC oil patient registry. Thank you. So patients need to have been diagnosed by a physician as having one or more qualifying condition and must have been certified by such physician to use the low THC oil. Patients need to have an active low THC oil card before they purchase the oil. And the cards are issued by TPH and are shipped directly to the patient. There's also an opportunity if you, for some reason, are not able to have the card shipped to you, we can ship it to one of the health departments near you and you can go pick it up there. Next slide for me. Thank you. This is our list of qualifying conditions. You'll note that all the ones with asterisks by them must be severe or end stage in order for patients to qualify. Additionally, I wanted to point out that in y'all's packets, you have a kind of a policy brief that details the difference in qualifying conditions between Georgia, Florida, and Alabama. So just so y'all can have an idea of how those conditions differ. And if it's okay with you, Mr. Chair, I'm going to toss it over to our program director, Blanca, who can just give a little bit better details. Thank you.
Okay. Good afternoon. So as Graham mentioned, my name is Blanca Tavera. I am the program director for the low THC oil program. I have been the director for a little bit over a year, but I have been working pretty closely with the program itself for a little bit over 2. So today I will be focusing on just our card distribution process, kind of explaining the steps that a patient or caregiver would have to take in order for them to receive their low THC oil card. But before really going into that process, I did wanted to add a little bit more and define what a patient, caregiver, and physician is in relations to this program in particular. So first, an eligible patient is a Georgia resident who has one or more of the qualifying conditions that were listed on the previous slide, while a caregiver is a legal guardian of an adult who has one or more of the qualifying conditions, or the parent, guardian or legal custodian of a minor who has one or more of the qualifying conditions. So in order for a patient or caregiver to obtain a low THC oil card, they do have to consult with a registered physician who has an active full Georgia medical license. Thank you. So a physician, only these physicians are eligible to register, or rather to certify a patient for low THC oil. They do have to have that unrestricted Georgia medical license. So once the physician registers within our system, and they are approved, that is when they're able to go into the registry and input that patient's and caregiver's information. And once everything is verified, that is when they receive their card. It is important to note that the low THC oil is not a prescription, it is a certification. So it is up to these physicians. They can decide whether they want to opt out of certifying a patient. And really, like I said, this is entirely based on like their judgment. So next slide, please. Okay, thank you. So a lot of you may already be aware of the bill that passed in 2024. So this was Senate Bill 495. It required the program to extend the expiration date from 2 years to 5 years, and then also to ship the cards directly to the patients and their caregivers' homes. Prior to that, we did have 43 participating county health departments that we would ship them to, and we would ship it, like I said, close to the closest like resident, the closest health department to the patient's residence. So it was on July 1st, 2024 that we expended the expiration date. So we went from that 2 years to 5 years. And then on October 17, 2024, that's when we began to ship the cards to the patient's homes. And this was because we did had to wait for the implementation for our payment portal. And that is what allowed us to receive the card fee from the patients and caregivers. So the card fee did increase during this time as well. It went from $25 to $30. And this really was a way for us to help cover shipment cost. So along with that shipment cost, we did update our protocol and you can move to this. Thank you. So this is what our new protocol is. This is the card process and the steps that a patient and a patient and caregiver will have to take, or the steps that would have to take place in order for that patient and caregiver to receive their card. So once that physician inputs a patient and caregiver into our registry, the program does see that information instantaneously. However, it is important to note that depending on the physician that the patient sees, this time does tend to vary. Some physicians are really good at it. It would be like a couple of days and that information is input in our system. Other physicians might take a little bit longer. So from there, once we do see that Yeah, so from there, there's two ways that it would go. If all the information is updated and correct in our system, we go ahead and verify the patient, and I'll come back to that in a little bit. But on the other side, if we do need additional information, this could be if like we don't have an email address on file, or if a driver's license wasn't uploaded into the registry, that's when my staff will reach out to this patient or caregiver and just request that additional information. Sometimes we do have patients and caregivers who aren't comfortable giving that information, and given, all the scams, it makes sense. So we do always give them the option for them to reach back out to their physician, and they upload that necessary documentation if need be. So moving back to when a patient is verified, once a patient is verified, they do receive an email that'll basically prompt them to pay for their card. They can pay the card in two forms. So they can go through our payment portal and pay for the card. For this, when they go through the payment portal, it does have a total cost of $33.75. So the $30, as I mentioned before, is the card fee itself, and there is a $3.75 processing fee for using the portal. If they don't want to take that route, they are also able to send a money order. They can mail it directly to our office. And for that, it's only like the flat fee of $30. So once we receive that payment, that is when we ship the card out, or we print the card and then we ship it out to them. So we ship it out through UPS because we do have to ship it out through certified mail. We do require a signature upon delivery. For this instance, we are very careful with how we create our labels with UPS. We do add like I guess, the option for patients to receive those email notifications. That way they can like kind of track their package. They're also given the opportunity to like pre-sign if they need to, or kind of update their delivery date as well. So once the card is delivered, it's either delivered to the patient's or caregiver's homes, as mentioned before, or like Graham mentioned, for certain occasions, and this is usually only applicable to patients who don't have a permanent residence, or they have a PO box because UPS won't be able to deliver it to them that way. What we do is we ship it to the closest participating county health department. And then from there, once we get notified that that county representative, the county representative that helps us with the program has received it, that's when we will reach out to the patient and inform them that their card is ready for pickup. With all that, this process, we do ask patients and caregivers to allow us about 7 to 10 business days for them to receive the cards from the time that that a physician inputs that patient's information into the registry. However, if everything goes smoothly, like the physician added their information pretty quickly, the email is good, their documentation matches what we have on their file, this process can take as little as like about 3 to 5 calendar days. And that really concludes it. That is how our protocol currently is, given the changes that we've made. And yeah, that really concludes my time. Thank you.
Thank you. Thank you
so
very
much. I'll go ahead and hand it over to Amanda.
If we can just hit the high points, we do have I know, including the Composite Medical Board, but we have 2 other speakers and several from the public that would like to have time. So please try to hit the high points. Is there hang on, there is a quick question while you're, go ahead, Chairman.
Thank you, Mr. Chairman. I want to ask a question to the lady. She doesn't mind.
I thought you made it to sit down.
I don't know if I missed this, but originally when we instituted this program, when someone goes to the doctor and the doctor verifies that they suffer from one of the legal ailments that they may have, what is the process then? Does that doctor send that information to public health?
So we have our registry is in our SEND system. So when a physician registers, it's basically them like creating an account in the system. They do have to put like some their license number, and we do cross-reference that with the CMB. And if all the information matches, they're auto-approved and they go ahead and have access to the registry. That's when they're able to go in and input that information.
The reason I asked that question, when this program originally started, a lot of these patients had to go to a specific public health department.
Mm-hmm.
And a lot of the questions that we had at that time, sometimes there was 70, 100 miles between them.
Yeah.
Northeast Georgia, at that time, most of the counties outside had to go to the Clark County Health Department, which in some cases was a sizable distance for a lot of these folks. Is that not the process now?
No, like if you're, I guess, talking about them getting input into the system, that's not a requirement. Are you talking more relations to them picking up the card itself?
No, this used to be the application process.
Okay, yeah, no, that's
So
not a.
you're saying that
yeah.
the doctor has a
Yeah.
portal to go in. All the doctors have a portal they can sign up and go into.
Correct.
And the patient also signs up for a portal.
No, the patients don't have access to the SEND system. It's just the physician. The patients are able to kind of monitor their card status though with this like portion on our website that we have that allows them to check their card status. But in terms of the portal itself, no.
So a patient, the doctor sends this into that doctor approved portal, and a patient goes to your website, sets up a account maybe?
No. So a patient will meet with the physician that's registered within the system. The physician will though log into our system, and then they will input that patient's information into our portal. And then from there, we'll go through the processes and then just ship the card out. Just the patient's a little bit more active now in terms of them having to like pay for their card and that kind of stuff. Does that make sense?
We'll talk offline.
Sounds good.
Thank you. Once again, high points. Thank you.
Yes, thank you. My name is Dr. Amanda Felpash. I'm the Deputy State Epidemiologist here in Georgia. I oversee a number of epidemiology programs, but low THC epi support there is one that I work on. So I just have 3 brief slides. So in August 2023, we were engaged in epidemiology to look at the data management, collection methods and analysis for this. After a full review, so this was done with in-kind support in epidemiology. We did not have any dedicated low THC epidemiologists at the time. But we made some changes to address immediate needs in the SIN system that Blanca was talking about. So what that did is we implemented some data management that ensured the definitions of the active patients, active providers, and active caregivers were correct and displaying numbers accurately and consistently. With the support of the General Assembly, we were able to get a dedicated epidemiologist who has continued to provide critical ongoing support to this program. So in that first year, we've improved existing infrastructure. I think everybody here knows that infrastructure and improving it is a team sport. So that includes working closely with our program, our colleagues at CMB and others to help put the data into action. So bridging the gaps between what program needs and what our technological supports are. Some of the legislative changes like extending cards to 5 years, we were able to help implement that seamlessly within the system to ensure that patients were counted correctly so that those numbers could be used for important decision making in this program. We've also implemented some new provider and patient management tools. So what Blanca talked about providers going into a portal and certifying patients, certifying that they have one of the qualifying medical requirements. We streamlined that. We made access for providers easier. We made cross-checking with CMB data on full active licenses easier. We've gotten a lot of really good feedback about that and a lot fewer complaints, which is always great. With this is my last slide. Go ahead, Graham. So to talk a little bit about patient growth and what that looks like in application. So as of July 23rd, we had just over 33,700 patients, active patients. So those are people who have a card that is not expired, it has not been canceled, and that is tied to them. About 2,300 caregivers and 772 active physicians. An active physician is a physician that has at least one patient that is active within the registry. The top 5 conditions are listed here, but one thing that we do note is that the top 2 conditions account for about 76% of the cards issued. But I do want to note that patients can be certified. When they are certified, they may have more than one condition. So this doesn't mean that those patients may not also have cancer or may not also have another condition, but PTSD and intractable pain are 2 most common certified qualifying conditions. The last thing is off here to the right. You can see the steady growth within the system. These are our active patients month over month since October 2024. We've steadily seen about a 3% growth in the system each month. This also includes one of the data management things that we did that I think is really important is that we now manage patients, providers, and caregivers on a daily basis. So every day we remove patients that are canceled by their providers, whose cards expired, or who are matched. We actually have a vital records daily match. So if we identify them as deceased, we are always also able to manage those in real time on a daily basis. So these numbers are much more accurate and much more consistent. And that is all I have. Thank you.
Quick question before you go. It's in epidemiology. A lot of times you look at efficacy, and I do know that I think we'll hear in a minute from the composite board of medical examiners that we're going to hear that doctors are supposed to report the condition, a dose that the patient may plan to take, and a follow-up either every 6 months or 12 months. I'm not sure what it is. Are you able? Your epidemiology role doesn't include looking to see, did it really work for PTSD? Did it work for ulcerative colitis? Or does it? Are you able to do that? Or is there not enough data right now?
Yeah, so we do look at the data that's reported to us by physicians. And, some of that information is available through them reporting whether or not someone's still taking low THC. That's something that we can also use as a marker for efficacy. We do have providers when they discontinue certifying a patient, they may say they're no longer taking it because they didn't find it effective or they're using other medications. And we see very few of those in our data, but we are new to this. Again, EPI is the newest kid on the block with this, but we've worked really closely with our program team team and also again CMB to help plan for looking at those data longer term to have some better answers on that. But we are able to look at that and do provide ongoing reports to our stakeholders here as well to help with that.
Thank you. Thank you for your presentation. CMB, the Composite Medical Board. Thank you for, go ahead, Mr. Jones. Highlights, great. Thanks.
So GCMB, we license the physicians that provide the service. They have to be active in Georgia. They can be in-state and out of state as long as they're licensed in Georgia. So we do have some that are out of state. They have to have a doctor-patient relationship, and I'll get to that in a minute. Determine eligibility for qualifying conditions, treat the patient for that specific condition, and provide, explain, and obtain a signed board-approved waiver form, which can be on the DPH website. So all that is done. There's a semi-annual report that the physicians have to do and report to the board as well as DPH. We just got that, I think, in May, March, something like that, April. So we're reviewing that now. So they have to do
semi-annual report from each of the physicians regarding each patient.
Yes, sir.
Okay, thank you.
Yes, sir. So the physician reporting and record keeping, physicians that are certified to do this must file that semi-annual report with the patient registry number, conditions treated, reported dosage and concentration. Sorry, I'm ahead of myself. Can you do that? Adverse effects, drug interactions, compliance, and ongoing treatment status. So they have to provide that to show how the patient's being treated and how they're interacting with that treatment. And early reporting is required of physicians if patient care ends before the next reporting period. So enforcement and discipline, we're obligated to do the enforcement and discipline for this. There's a law and a rule that goes along with that with unprofessional conduct. So we have investigators and hopefully some inspectors soon that can help with that process. The key duties of a physician, certify only qualifying patients for low THC, maintain accurate patient records and sign waivers, file required semi-annual reports, adhere strictly to board and DPH protocols, and comply with all board regulations to avoid disciplinary action. So Georgia licensed in-state and out-of-state physicians' responsibilities. There's no real difference between the two. They still have to have the same requirements and the same licensing as each other. So there's no difference in that. But a physician who's outside of Georgia but not actively treating the patient or lacks an ongoing doctor-patient relationship does not meet the requirements to certify low THC. So you have to have that patient, physician-patient relationship.
You mentioned the word ongoing, which is a little different because a lot of people have called up for a sinus infection to an online.
Yep.
I mean, they do have a doctor-patient relationship in that 15 minutes.
That's right.
But nobody would call that an ongoing. Does the rule specifically say you got to have an ongoing?
It does. Yes.
Okay. Thank you.
So an ongoing relationship and
Different. Yeah.
yes, sir. Those things could change through that treatment. What is efficient physician-patient relationship? So we have a rule 360-36.01, subsection 6. A doctor-patient relationship means the physician must be the patient's primary care or specialist physician treating the patient for the specific condition requiring treatment by low THC oil and must be maintaining patient records supporting the diagnosis and treatment of the patient. So there has to be that ongoing patient record that says, hey, we're treating them for this. This is the outcome. This is the changes, or this is how it's going. So there's a difference between a physical exam and then a telemedicine exam. So a physician using telemedicine is held to the same standard of care as if the patient were present in person, which I'll get to that, the caveat to it. A physician-patient relationship must be established for telemedicine services to be initiated. So they still have to have that patient relationship. And it can be, the relationship may be established without an in-person encounter, provided the standard of care can be met. So there's certain things in the practice of medicine that they have to meet to do that. The relationship must involve an assessment of the patient's medical history and condition, diagnosis and documentation, patient consent, and appropriate record keeping. So, and prescribing of controlled substances via telemedicine is prohibited unless there's at least one in-person encounter prior to that. So electronic means with a physical patient relationship in this rule, a Georgia licensed physician, physician assistant, or advanced practice registered nurse, they have personally seen or examined the patient and provides ongoing or intermittent care by electronic or other such means, or is providing medical care by electronic or other such means at the request of a physician or physician assistant or advanced practice registered nurse licensed in Georgia, who has personally seen and examined the patient, or, this is the caveat of the electronic means, is able to examine the patient using technology or peripherals that are equal or superior to an examination done personally by a provider within that provider's standard of care. So with that, the peripherals and the items used for that examination, depending on the condition, will establish this, whether it has to be in person or whether it can be telemedicine, depending on the peripherals used and the examination that's needed for that condition. So it depends on the practice of medicine and that medical doctor to assume that role and make sure they're doing the right thing. About that. So we have partnered with DPH. As soon as I started as the executive director, Dr. Toomey come up to me and said, hey, we need to look at this. So we started working on it, and they've been great with that process. So what we're doing is constant review of physicians treating patients, create a public outreach campaign, which we did along with DPH, begin proactive inspections. I was able to get one inspector this year, but I know we're going to need more to be able to do this along with others because just the patient volume that we have. And then we're also behind the curve because we haven't been doing these inspections as we should. So we're trying to play catch up with what's going on here. We did have a new license database that started this month. It's a little chaotic, but we do have a low THC oil checklist. So a physician that is doing this will check this. And then we know that they're doing this for sure. But they also have a checklist for that. And then we're also going to begin collecting the data for semi-annual report through that system, which is going to help all of us make sure we stay in touch with what's going on. So this is our public outreach. We did do a brochure. We do have things on our website, and we also are about to conduct inspections. We hired a guy that's going to start August 15th, and this is his first task. So hopefully that was quick enough.
That was very, very concise. Thank you very much. Any questions from members of the committee? And by the way, we do have one of our committee members out of town on a family emergency, but joining us by Zoom, Representative Spencer Fry. We can work to get you on if you need to, or you can text me a question, Representative Fry. I'm going to start over here with Chairman Dickey.
Thank you, Mr. Chairman. I've just got a simple question. This presentation has gone through a lot of really in-depth, detailed process and procedures to get this product, patients to be able to obtain this product at dispensaries. What's the difference in the products at your dispensaries in which I can walk down to the smoke and vape shop and buy?
Yeah. So the low THC by definition is no more than 5% by weight THC, the oil. So it's, in many cases, I'm maybe speaking out of turn here, less than probably what you could maybe go get somewhere else. It's very little amount of THC.
So what's at the smoke and vape shop? You don't know?
I'm not sure.
That's not, we don't. Department of Agriculture would.
Yeah, that's
so.
Commissioner.
You want to? Go ahead.
To your question, Mr. Chairman, just really quick and for clarification, and they can clarify if I'm wrong, but low THC oil can only be purchased from a licensed dispensary.
Right.
So smoke and vape shops are not licensed dispensaries unless they have a license to dispense. But those are limited, right? So typically those facilities are one of the 7,000 licenses that are issued by the department, and/or we find that they might not have a license from us and they're supposed to, in which we take administrative action against them at that point. We'll issue a cease and desist, or we'll proceed, dependent upon the violation, with a practical arrest or just a full-on arrest, which we have done, either arrest by citation or custodial arrest, and we've done those too. In regards to the smoke and vape shops that you're referring to, they can legally sell hemp product as long as it meets Georgia law, our rules and regs, and it's below 0.3% total Delta 9. Does that make sense? If it's outside of that boundary, it is considered, and it's not being sold by a dispensary in Georgia, and it's above 0.3% THC, it is considered marijuana under Georgia law, which at that point would be, they would fall under Title 16, which we could pursue charges under that as the department. Does that answer your question?
Yes, thank you. That's great information. I was just really, so their product is stronger.
It is stronger than what we regulate.
That's what I want to make the committee.
Which is why that's why there's just the license structure that there is under the low THC oil program.
Yeah.
And specifically for medical use, only by or not prescribed by a doctor, but approved through a doctor.
Okay.
We're going to have a time at some point where we discuss less percentages and maybe more milligrams, because there's a very percentage by weight of a gummy versus a beverage versus a drop, half a drop of oil are varied, and the milligrams that go into the system is a piece of it. But we're going to look at it. Chairman Powell.
Sure, Mr. John. How many doctors do we have in Georgia that are prescribing, or excuse me, I don't think the right word is prescribing, that are verifying the illness?
Yes, sir. 732, I believe, is the current count.
Can you tell me how many physicians are in Georgia that are licensed?
I knew you were going to ask that, but I didn't prepare it. So, so out of those, probably 98%, I would think.
So you have a very minor percentage of doctors. Why would that be the reason that not all doctors are prescribing, since they're supposed to be serving their patients for an illness?
What I've gathered is it's a specific need, and some doctors don't want to delve into that need, because it could be for a specific condition that they're not treating, or they don't their patient population isn't within that. So they have a lot of doctors.
A lot of them don't believe that cannabis is a viable product.
That could be it too. Yes, sir.
They're not being paid a rebate then by pharmaceutical companies.
I think there's different ways there.
Oh, I'm sorry. I retract.
Just popping in here one more time to say that one way to help raise money for this channel is by purchasing something from our ASEA website. They've got all kinds of interesting supplements to help you be the best you that you can be. So check out the link below and let me know if you have any questions.
How many physicians are in Georgia that are licensed?
I knew you were going to ask that, but I didn't prepare it. So, so out of those, probably 98%, I would think.
So you have a very minor percentage of doctors. Why would that be the reason that not all doctors are prescribing, since they're supposed to be serving their patients for an illness?
What I've gathered is it's a specific need, and some doctors don't want to delve into that need, because it could be for a specific condition that they're not treating, or they don't their patient population isn't within that. So they have a lot of doctors.
A lot of them don't believe that cannabis is a viable product.
That could be it too. Yes, sir.
They're not being paid a rebate then by pharmaceutical companies.
I think there's different ways there.
Oh, I'm sorry. I retract that off the cuff.
The jury will disregard.
Could it be that a lot of the doctors are afraid because of the federal rules on classification?
That could be.
Afraid they're going to get into trouble with the feds.
We haven't done a study to kind of see why or why not, but I think there is more physicians that are signed on to it since we've been looking at it. So there's more physicians, and then our education program to show them, hey, this is what it's used for, and this is what you can do. I think since we started doing that, it's gotten better.
I'll be sure that I've got the right feel on this, but one of the things that when we passed the original legislation, this is supposed to be for medicinal purposes. Medicinal kind of sticks to the doctor or the medical profession to me, and it's kind of backwards, because the only thing doctors can do is verify that patient has one of the legal ailments. to do this. So it seems like we've created kind of a backward system. And the reason I'm saying that is because there's been a lot of discussion in recent years that one of the things that possibly needs to be considered because of the illness that some of these people suffer from is that maybe the doctors need to be able to prescribe both the strength and the delivery system to these patients. You take someone with a terminal disease, somebody may have end stage, whatever the disease may be. Does it really make a whole lot of difference as long as they're getting some kind of relief? And I think has been the driving force behind that, the possibilities of that change.
Yes, sir. We can discuss that so I can get it to the board and we can see kind of what they're.
Please do. I'd like to hear what their thoughts would be.
Yeah.
We do have one other question. Another member of our, in addition to Representative Fry on Zoom, we have Representative Michael Smith. If we can pull you up, we're going to try to pull you up on the computer. If you can ask your question, sir, and we're hitting the highlights. But welcome. Representative Smith. We'll keep moving. Feel free to text me or my analyst your question, and we'll move forward. I think with that, I believe that summarizes. Is that correct? Yes, sir. Thank you both for being here and enlightening us. Thank you for the work we can look at home as well to better understand this, and for the data that you're bringing. And we also, like we said earlier, we may need to hear back from you a little bit more as we learn more about this and learn what direction we think the legislature ought to go.
Yes,
we are going to transition now. Those are two departments of the state. We do have two groups here. Georgians for Responsible Marijuana Policy. If I could invite you all up, either to the table or to the podium. I'm going to ask you to try to, I know it's brief, may have prepared a lot, but if you can try to hit the highest points, and if you don't need to hit every slide, that's okay too.
Sure. Thank you, Chairman. Thank you, committee members. My name is Michael Mumper, the Executive Director of Georgians for Responsible Marijuana Policy. We're a nonprofit launched in 2017 to protect the wellness and public safety of Georgians from the harms of marijuana through evidence-based research and education. We do support compassionate care, but we are concerned that the current direction of marijuana and hemp policy in Georgia is losing some ground in public health and medical science. We're here today to raise three key issues related to intoxicating hemp-derived products like Delta-8. Two is current hemp consumable law. And three is the expansion of medical marijuana policies that are being proposed. And to bring these concerns to life, we brought a team of 5 other people as well. So I don't know if you want to ask me questions after I'm done. Each of us is only a few minutes. So I'll leave it up to
just a couple of minutes each. That would be helpful.
Okay. We have 2 parent advocates, 1 youth advocate, a licensed professional counselor, and a board-certified addiction medicine physician. 3 concerns. 1, proliferation of unregulated Delta-8 and similar products has created a public health crisis, as evidenced by Georgia Attorney General Chris Carr joining 21 other attorneys general to convey this message to Congress. These products can exceed 90% THC and are sold legally in gas stations and online.
Did you say 90%?
They can be.
So not 0.3, or it has a different type of.
Yeah. No, I'm sorry.
It's a different type of THC. One of the other.
Delta-8. Yeah, Delta-8 THC is not regulated. So only Delta-9 THC is regulated as far as potency goes.
Thank you.
Yes. And if you went to certain websites, you could buy 90% vapes and have them shipped to your home for free. Secondly, Georgia's law limiting Delta-9 THC to 0.3% by dry weight sounds protective, but in some practice, it is not. For example, a 3-ounce blueberry muffin, 85 grams, can be 0.3% THC or less and still have, if you do the math, 255 milligrams of THC. Now, when it only takes you 10 grams for a new user to get high, 10 grams, or 60 milligrams for an experienced user, 255 milligrams is mighty intoxicating stuff. And this is the legal stuff. This can lead to increased emergency visits and hospitalizations that Georgia is experiencing, rises in both of those. Thirdly, current medical marijuana proposals propose to expand Georgia's medical marijuana program with little scientific justification. Raising THC limits from 5% to 50% is not supported by any major medical association. There are no randomized controlled trials supporting this. High potency THC is associated with psychosis, cannabis use disorder, and cognitive impairment, especially in youth. Peer-reviewed studies show that high THC products, those with over 10 or 15% THC, offer no added therapeutic value, but add considerable risk. The Lupus Foundation, for example, does not recommend marijuana as treatment for lupus. The Departments of Defense and Veterans Affairs do not recommend cannabis for PTSD. And removing the severe or end-stage requirement for qualifying conditions is shifting Georgia closer to de facto recreational marijuana. Our concern, taken together, is that we're moving toward this recreational marijuana legalization. I can either take a question or pass it to
We do have a quick question for you, and then we're going to try to limit to about 3 minutes max. I know there's some difficult stories to tell, but we do have a couple of cards we'll use. Representative Williams.
Quick question, sir. That super muffin, that's already illegal under Georgia law, isn't it?
No, it's not.
That's in code. And I had a terrible muffin this morning, but I don't think it had anything.
Is it the Delta 8 versus Delta 9 restriction that you're saying makes it legal?
You know, that's a good point. If it's Delta 8, it's not under law. So it can have Delta 8 THC and be at 255 milligrams.
We're having 4 meetings. So we do need to trust but verify. Let's see if we can go ahead with the members who did want to speak, and I do appreciate you all being here. We do have about 3 minutes max. If you can keep it under that, that's great. Anna, our analyst, will hold a yellow card up when you got a minute left, and red when you've.
I appreciate it. So nobody records me. This is a very personal story. Oh, no. On your personal phones, just because.
I'm sorry, but this is public. I'm allowed.
You can't say
it. Okay, well, if
Thank you for being here.
Family, I will do it, even though it's very disrespectful to our son, but I'm here as a very personal story. Our 19-year-old son is staring a lifetime of schizophrenia in the face thanks to high-potency THC vapes, which he got freely and easily at the Smoke World chain here in Atlanta, starting at the age of 15. His favorite brand was Hidden Hills, with a THC concentration up to 90%. With flavors like Pinkonade, raspberry, and whipped watermelon, the only thing hidden in those hills was addiction, psychosis, and a family ravaged by heartache. He even had a discount frequent buyer number in their computer system at the tender age of 17. Throw in some high-potency gummies decorated in cartoon shark packaging, and you have a recipe for disaster. CHS, cannabinoid hyperemesis syndrome, has been part of our journey too, with our son throwing up out of his second-story bedroom window so often he lost 25 pounds. After attending an elite high school, he no longer dreams of a bright future, but struggles to stay awake during the day. Being a smart child, like his addiction, he was able to hide his mental illness from his family professionals for a very long time. His older brother, by 17 months, says he not only lost his brother, he lost his best friend. And we're the lucky ones. Our son isn't homeless, in jail, nor did he commit suicide, which is far too often the case. The system isn't ready for these kids. Ask any ER doc. It took 93 days for the THC to leave our son's body. Thank the good Lord he's over a year sober, but he still can't sit through an entire family meal, let alone a movie. This isn't going anywhere. The countries and states in which marijuana was first legalized have the most cases. I know firsthand because I sit in parent support meeting after support meeting with families all over the world, struggling with the ugly double-head monster that is cannabis-induced psychosis. This has been the biggest regulatory failure of my lifetime. I honestly believe that our son knew the true game of Russian roulette he was playing. He would have never played it. It's not just weed.
Thank you for sharing your story with us.
Hi, everybody. My name is Rebecca Flynn. I'm also a mother. I'm a mother of 5, and I'm speaking today on behalf of Georgians for Responsible Marijuana Policy. 4 years ago, my son, an honor student, a robotics team member, and an aspiring computer science major, had a psychotic break after heavy use of high THC marijuana products. He was only 18. What began as casual usage in social situations quickly became dependence. What followed was devastating: multiple hospitalization, homelessness, jail, and a diagnosis of schizophrenia. It really sucked, I'm telling you. Mary's a testament to the depths. His life was permanently altered before it began. This story is not unique. As Georgia considers expanding access to marijuana, I ask our lawmakers to pause and thoroughly consider the risks, especially to youth. The adolescent brain continues developing well into the mid-20s. Research shows high-potency THC products can increase the risk of psychosis, cognitive damage, and long-term mental health issues. Yet young people don't often understand these risks. Today, THC products are not the same as those from decades ago. They're far more potent, accessible, and dangerous to developing brains. My son saw marijuana as harmless, natural, even therapeutic, but that belief can carry serious consequences. Ask any ER doctor. That's why I support prevention, education, and access to treatment, not commercialization that targets youth. I also urge lawmakers to close dangerous loopholes that allow products like Delta 8 to be sold to teens at gas stations and vape shops with little to no regulation. Legalization is not the only or the safest path forward. Our children need protection, not easier access to a drug that can permanently alter the course of their lives before they're old enough to fully understand the risks or their brains are fully developed. My son will likely never go to college, live independently, or raise a family. Please do not let his story become the story of more Georgia youth with so much potential and so much to lose. Thank you.
Thank you for sharing with us. Please.
Hi. Good afternoon, members of the committee. My name is John Harriet, and I'm a high school junior from John Street, Georgia. I'm here today, like many of my peers, as a student who is quietly navigating a problem that most adults do not even know about, which is the hemp loophole. Let me be clear, most students like me do not call it a loophole. To me and many of my peers, it doesn't exist. It feels normal, it feels legal. Delta 8 is in gas stations, convenience stores, and advertised online in bright and flashy packaging, which is advertised to my generation. It's mixed into gummies, sodas, and brownies, and is completely available to us in a wrapped box. Just another thing we can try. Students don't see a difference between this and marijuana. In fact, most don't even, And that's the real danger. When a product gets too high, sitting next to candy bars, we stop questioning it. When no one talks about it or enforces limits at stores, we assume it's no big deal. When students like me bring it to school, we use it between classes or brag about how easy it is to get, it becomes part of our culture. It starts to become a part of our happiness and spreads like a plague. I'm not here today to lecture anyone on drug policy. I'm here today to state that if the goal is to keep students safe, like me, then we have to stop pretending that this loophole does not exist. Right now, the message that we're getting as a generation, and the message I am also getting today, is that no one here really cares. That's why I'm asking you to close this loophole, to add clear packaging, to limit potency, and if we do not act now, we're normalizing high potency THC in a generation that has not even graduated yet. Thank you for your time and for listening to a voice of someone who sees this from the inside.
Thank you for sharing with us today. Yes, sir, please Introduce yourself.
Hi, my name's Britt Paramore. I'm a licensed therapist in practice in Woodstock, Georgia. I have some slides, but I don't need them.
Thank you.
I can go. So I specialize in the treatment of severe and persistent mental illness in children, adolescents, and adults, and the treatment of substance use disorders, along with the treatment of veterans with trauma-related disorders. 2019, had a 16-year-old come into my office with a schizophrenia diagnosis, which is rare. It happens, but usually there's a family history or methamphetamine use that did not apply to this 16-year-old. He just told me he'd been smoking something called carts, which I found was short for a cartridge that contained over 90% Delta-9 THC. I thought I had a rare case. I didn't think that could cause it. But then fast forward to today, I've got 20 plus patients who have developed schizophrenia, which is permanent unless something changes, just from using high THC Delta-9. And so I'm here to address specifically just THC level. I'm honored to, it's my second time speaking in this chamber on this same topic. And so since 2009, there's been voluminous amounts of research into what we call the causal effect of THC in schizophrenia. One of the leading researchers in the United States, Dr. Eric Messamore, who has been a schizophrenia researcher for a lot of years, to quote him briefly, the fact that there's a causal link between high THC products and schizophrenia is quite certainly the most evidence-based new research in the field of psychotic disorder research. And so I have a lot of views on Delta-9, but specifically the higher the THC limits go in either medical marijuana, we already have it in Delta-9 and Delta-8 high levels. I just implore this committee to do research into what I'm seeing every day in my little small practice in a North Georgia suburb with 20 patients who have developed irretractable permanent schizophrenia. It's medication resistant and the worst I've seen. I've been treating people with schizophrenia for 20 years and I've never seen anything like this. Thank you.
So briefly, we do have a couple of questions, if you don't mind. You mentioned several times high potency THC. Do you think these conditions would have never occurred if it had been the lower levels that we're trying to navigate at this point of a 5 milligram max or 10 milligram max? Do you think it was the high potency, or did that just affect the numbers? Or
yeah, sure. There is a high likelihood this wouldn't have occurred at 5%. It wouldn't have occurred at 15%.
It's percent and milligrams, though. Can you help us?
I'm talking about oils. And so it's if you take an oil of an ounce and 90% of it by weight is THC. That's what I refer to as a high concentration. While most of the research is done with, and this doesn't happen in adults, only adolescents in the developing brain. I've got a 3-hour presentation on why.
Under 21 or under 25 or?
Under 26 in males, probably under 25 in females, but the most common age I see it is age 12 to about 17. I haven't seen it a whole lot in people 20 and over.
But the developing brain, you're saying, is 25 and
up to 25, but I've rarely seen a case of someone over 20 develop the permanent severe symptoms.
So if we were able to stop it at 21, that might eliminate much of what you've seen, or?
I would say that doing anything you can do to prevent people under 21 from getting their hands on THC over 50% or over would go a long, long way to preventing a lot of this.
Okay. Once again, we are going to have to have a brief lesson on milligrams that are absorbed and percentages that are started with. But thank you very much. We do have another question from Representative Williams, or I'm sorry, Catherine. Sorry, Ms. Russell.
Just a point of clarification.
Sure.
Were you speaking primarily about Delta-9, or do you have any experience recognizing that there are other cannabinoids that seem particularly problematic?
I do. And, the research I've done to date has been primarily with Delta 9.
Okay.
It's only been in the last year and a half, I've started seeing patients who have not consumed the illegal Delta 9 oils, which is a felony in Georgia. It's only been in the last year and a half. I've seen they have 6 patients right now who never consumed that. They were only consuming Delta 8 at high concentrations they could get in vape shops and gas stations.
So you're not seeing like THCP or HHC or any of that?
So it's when I say Delta 8, let's use the term other than Delta 9. Delta 8 is the term I hear used most often.
I think what's challenging is identifying which of those cannabinoids are intoxicating at what levels. And there's just not that much data. So anything that you could offer.
Sure. So anecdotally, I can tell you, and I've asked tons and tons of the kids I see who have used regular Delta 9 cartridges and the high potency THC. I asked them, can you tell a difference in the way it makes you feel? 90% of them said, I can't tell any difference. In fact, they often say, this is it's a joke. This is just, it's pot under our high THC under a different name. Is what they tell me. Once again, that is anecdotal from my practice.
Well, we don't have anything else.
Right. Yeah.
True. Yeah. And once again, going back to some of the question about the doctors who are reluctant to prescribe this as a Schedule 1 agent, there's not a lot. So there may be a reason that some physicians are afraid to, I won't say prescribe, but even get involved in recommending or certifying conditions, is that there's no research that shows it helps. And there's no research that shows it helps because of the Schedule 1 capacity at the federal level. So any federally funded institution would be afraid to do this kind of research. So that, I know that's all evolving at the federal level, but that is a reason that physicians might be more reluctant to recommend it. Now you're going further the other direction and saying, not only would you not recommend it, you would certainly warn in anything under 21.
Yeah, for sure. And the THC level is what I'm most concerned about. And there are private institutions who are doing research, obviously, because of the Schedule 1 status. And so there is a organization called Johnny's Ambassadors, who I believe are the leading researchers, at least in one of the leading researchers in the United States right now. They have a board of doctors who are some of the top in the field who are researching this. So it's Johnny's Ambassadors is what I would search for.
Thank you, sir. And speaking of doctors, Dr. Murphy, are you next? Is that right?
Thank you.
Thank you, sir.
Thank you, everybody. My name's Colin Murphy, Dr. Murphy. I'm a psychiatrist, and I am triple boarded in adult psychiatry, child and adolescent psychiatry, where I trained in Augusta at the Medical College of Georgia, and addiction medicine, where I hate to say it, but I trained in Gatorland, UF. So my apologies. Please do not hold that against me. So I just wanted to, wrap things up and talk about some trends that I've seen nationally and I've read about. I had a couple of slides, and I've presented slides in other presentation. One is that shows inverse or opposite relationship between the perceived risk of substance use or marijuana use in particular, and the percent of people that, and this was like they surveyed 12th graders, so 17, 18-year-olds that had used marijuana. And there's a opposite, and it traced from like the 60s up to about 2019. So right now, and since there's a peak of perceived risk in the early or late 80s and early 90s, those of you that are old enough, that's, Just Say No, Nancy Reagan, Mothers Against Drunk Driving, a lot of public awareness, and those public awareness campaigns have kind of faded into the background. So there is a very low perceived risk in our youth. And there's also correlating with that, since the 60s, there's been a steadily increased potency or milligram per bag of I'm talking about flower marijuana, like going back to like Woodstock weed, for you boomers. That was about 1 to 2% THC by weight. In the 90s, for you Gen Xers like me, it was up to about 5%. And this is based on average content on DEA seizures. And it's gone up to like 18 to 20% now. And there's a direct correlation with potency of marijuana and the incidence of cannabis-induced psychosis. So like when kids were passing around a joint in the 60s versus kids passing around a joint now, the milligrams they're getting is about 10 to 20% more. Just briefly, in Canada, I'm referring to Canada because they have nationalized medicine, so they have an immense database. Cannabis attributable inpatient hospitalizations for psychosis about tripled. Cannabis attributable ED visits increased by 113% from 2007 to 2019. So this is relatively recent times. In Denmark, they have another nationalized system. The rate of cannabis-induced psychosis has tripled from 06 to 16, and there's also increased the diagnosis of that psychosis and schizophrenia, which is permanent. The brain development goes until 25 years old. There's correlations that the adolescent brain is more sensitive. And out of all substances, conversion from the acute psychosis you might see in an ER to a quote sticking as schizophrenia. By numbers, it is highest with cannabis, not crystal meth, not cocaine. It's highest with cannabis, up to like 34%. So this is real.
Thank you for your presentation, and thank you, Mr. Mumper, for putting together things for us, and I appreciate that.
Oh, one last thing I did look up, Delta 8 is about half as potent as Delta 9, so it's no slouch, and it binds to the same receptors.
Oh. Okay. Yes, go ahead.
I just have a quick question. Will you share your source on that point, data point? Can we talk about it later?
Yeah.
Okay, thank you.
Which data point?
How potent Delta 8 is compared to.
Yeah, sure.
Thank you.
That's all we have. Is there any questions before we have a seat?
I think that was some helpful information. Thank you for you and those that came. We'll move along to smart approaches to marijuana. That will be through our, I guess, a presentation online. Here. Oh, sorry. Excuse me. For some reason, I didn't know.
Surprise.
Well, welcome. Thank you for being here. Obviously, we are trying to hit the high point, so we leave some time for public comment. Thank you, sir.
Of course.
Thank you for traveling this way.
Yeah, of course. I'll be as quick as I can. I want to begin by thanking Chairman Newton and the members of this committee for giving me the opportunity to speak today. My name is Iman Larosby. I serve as a federal and state policy associate for SAM, Smart Approaches to Marijuana. SAM was founded in 2013 by former Congressman Patrick Kennedy and three-time White House policy advisor Dr. Kevin Sabet. SAM advocates for a health-first approach to marijuana policy, aiming to reduce use and prevent the commercialization of a new addiction-for-profit industry. Before I dive in to today's two main topics, intoxicating hemp and medical marijuana, I would like to take just a quick second to talk about some data and research that we're seeing from around the country regarding marijuana use, daily marijuana use, adolescent marijuana use, and what marijuana legalization looks like in the states that have tried it. For starters, what we know is that the drug that is being sold in stores around this country and that is being dealt by people on the street is a much stronger and much more potent form of marijuana. It can be up to 30 times more potent than the 3 to 2% marijuana that was used in the 70s, often referred to as the Woodstock weed. Increases in potency, commercialization, and normalization have had consequences, have had real consequences for people around this nation. For example, the CDC has found that 30% of marijuana users develop marijuana use disorder. Marijuana use is linked to a higher risk of developing psychosis, depression, anxiety, schizophrenia, and suicidal thoughts. In fact, daily users are actually 5 times more likely to develop psychosis than non-users. Furthermore, in 2024, the American Heart Association found that daily marijuana users face a 25% higher risk of having a heart attack and a 42% higher risk of stroke compared to non-users. And what we know is that marijuana use among adults is dangerous, but marijuana use among adolescents, well, that is even more. For example, adolescent marijuana use is linked to permanent changes in one's brain, including a decrease in up to 8 IQ points, and an increase in the odds of developing depression and anxiety. Furthermore, a study conducted by Columbia researchers found that teenagers who use marijuana are up to 4 times more likely to develop depression and suicidality than non-users. I've discussed the data. Now let's look at what legalization looks like. In Colorado, since 2013, when marijuana was legalized, they have seen a 138% increase in traffic deaths where a driver tests positive for THC. Furthermore, today in Colorado, the most common found substance in the toxicology reports of children aged 10 through 19 who take their own life is marijuana. In Denver, researchers have found that neighborhoods next to marijuana businesses experience up to 85 more property crimes compared to areas that do not have a marijuana dispensary. It's very important that I explain some of the harms related to marijuana use and the legalization of it, because intoxicating hemp products like Delta-8 carry many of the same risks and health effects. As many of you may know, the 2018 Farm Bill unintentionally opened the door for hemp-derived, kid-friendly THC products to be sold in stores nationwide. Lawmakers never intended this. In fact, that we know, the main architect behind the 2018 Farm Bill recently said it was a mistake. What we know is they meant to legalize industrial hemp, not these THC products that we're seeing, not these gummies, not these chocolate bars. No, they meant to legalize industrial hemp, which is used to make bags and ropes. Furthermore, what we know is that Delta-8 is nearly identical on a chemical level to Delta-9 THC. It's addictive, and it can carry many of the same health risks, as I noted earlier. According to the FDA, Delta-8 THC use is known to cause hallucinations, vomiting, tremors, anxiety, dizziness, confusion, and loss of consciousness. Additionally, from 2021 to 2025, there were over 10,000 poison control reports of Americans being poisoned by Delta-8 THC. In fact, many of these reports were young children. In 2022, a young girl died after eating Delta-8 THC edibles. She found her mother's supply and she ate it. The Virginia Department of Health found that the sole cause of death in this young child was Delta-8 THC toxicity. In 2024, a Monitoring the Future survey found that 12% of 12th graders use Delta-8 THC, an increase from the year before. And you know, these statistics, they're not surprising when you look at the type of product that is being sold. I mean, these are gummies. These are chocolate bars. As mentioned earlier, these are products that you find next to other forms of food and you know, these are meant to be marketed for kids. And you know, the intoxicating hemp industry will look at you in the eyes and say, well, you know, adults like gummies too, but is it worth it? Absolutely not. Quote unquote regulation of these products is no different than legalizing marijuana, full stop, which is why I'm here to advocate for a complete ban on intoxicating hemp products. Speaking of legalizing marijuana, let's discuss medical marijuana. We at SAM fully support the FDA's drug approval process, which is why I believe it is reckless to promote medications that have not gone through this process. We support the development of FDA-approved medications that can be prescribed by a doctor, dispensed by a pharmacy, and subjugated to the appropriate controls. In fact, there's real examples of this. Marinol. Marinol is an FDA-approved medication that is derived from marijuana.
Not gonna lie, one thing that I think is important to share is, I've become orange again. It's super challenging to regulate. at the Capitol building. I don't know if it's the lack of fresh air, the lack of plants, the lack of truth. But just be kind to yourself if you go down there. Like, just before I filmed these little intro outros, I was outside working in the heat. And when I came back in, I was like so hot, you know? I had to regulate my body temperature, and what really helped me was eating a whole bunch of juicy grapes and getting hydrated and feeling those electrolytes. So, you know, be kind to yourself. It took me a couple of days to get back into actually posting this, because I feel like I just had to regulate myself vibrationally after being in the Capitol. I think honestly part of it has to do with the fact that I'm not paid to go down there. You know, we have to volunteer our time, and that makes it hard to regulate financially and to just survive in this world. Like, to feel like, oh, to make that time, it's such a sacrifice, right? And I do appreciate everyone who's donated to my parking in the past and whatnot. I just can't always depend on that, right? So I think that's part of it, is that, you know, you go down there and then certain people are being paid as experts to do consultations, or obviously legislators are getting paid, and it just feels out of balance. Like, why aren't they paying to consult with us, right? Why aren't they valuing us coming down there and sharing all this amazing, like, stuff that we've learned throughout the years? And it's a little bit backwards that we're not being honored for our knowledge. All of you, I know some of you went to cannabis universities. So just be kind to yourselves. You know, this world is filled with challenges, and we just have to take one day at a time in making sense of it. And one thing that helps me regulate after stuff like this is to know that we are all in this together, and we're all sacrificing in different ways, and to just feel so much gratitude for everyone who's come before me and what everyone is doing now. And literally, this has to end. So it's like gardening, you know, it's a lot of hard work, but eventually you do get to harvest things that really fill you with nutrients. So keep up the good work.
Of course, safe and effective, of course, is not a fitting description for the drug that is being prescribed by so-called bud tenders at dispensaries across this country. And, you know, furthermore, you will see that proponents of medical marijuana will tout it as a cure for many different ailments. For example, the first I'd like to address is that medical marijuana is a fix to this country's opioid crisis. To begin, the Stanford School of Medicine found, and I quote, "There is no connection between medical marijuana laws and reduced opioid deaths." Furthermore, the Columbia Mailman School of Public Health found, and I quote, "There is no change in opioid use following the adoption of medical marijuana laws." On the other hand, there's actually bounds of research that shows that medical marijuana may actually worsen this problem. A study done in Addiction, which is a prominent scientific journal, found that marijuana use not only failed to replace opioid use, but it promoted it. The author of the study went on to say, and I quote, "Our study provides further evidence that marijuana use is not effective in reducing non-medical opioid use." Another common claim from the industry is that medical marijuana is a safe and effective treatment for veterans who suffer from PTSD. I sympathize with the veterans in this country. They deserve real treatments, not false promises. In fact, marijuana has actually been shown to worsen many of the symptoms. For example, in a joint work group, the Department of Veteran Affairs and the Department of Defense declared the following, I quote, "We recommend against cannabis or cannabis derivatives for the treatment of PTSD." Furthermore, the work group goes on to say, noting studies saying adverse psychiatric outcomes associated with marijuana use in patients with PTSD include depression, anxiety, psychosis, and substance misuse. Furthermore, they go on to say possible treatment-related serious events such as suicide attempts, paranoia, and agitation. Furthermore, you can go on the Department of Veteran Affairs website for PTSD, their National Center for PTSD, and they say, research to date does not support cannabis as an effective PTSD treatment. And they go on to say, in fact, some studies suggest cannabis can be harmful. They go on and you will see that veterans in this country are being treated like guinea pigs. We're pushing a drug that has not been proven to cure PTSD on them without real credible evidence. But sadly, as this push has happened, we have started to see the real consequences. Let's look at it. Today, 12% of veterans with PTSD have cannabis use disorder. In 2022, nearly 9% of veterans who took their own lives were diagnosed with marijuana use disorder. Since 2001, this number has increased by close to 20%. Once again, I'll say our veterans deserve real treatments, not false promises. And moving on, while we debate whether to expand the medical marijuana program here in Georgia, I'd like to actually talk about what we're seeing in other states that have. In Pennsylvania, there have been reports that show that some doctors actually prescribe more than 10,000 medical marijuana cards yearly. 10,000. In Colorado, one study found that 83% of medical marijuana dispensaries are recommending marijuana to pregnant women. Furthermore, one study has found that 81% of medical marijuana users also use the drug recreationally, compared to just 19% of users who use medical marijuana exclusively for medical purposes. In conclusion, Sam advocates for a complete ban on intoxicating hemp, as any attempts to regulate these drugs would be legalizing recreational marijuana. Additionally, Sam also opposes the expansion of Georgia's medical marijuana program, as doing so would put real people at risk while filling the pockets of an addiction for profit industry, the marijuana industry. I urge the members of this committee to prioritize public safety over the bottom line of an addiction for profit industry. Thank you for your time.
Thank you for your presentation. We do, if you can, give us some of your handout if you have one, and send it to us later that we'll get, so because we are going to be studying this for some time. If there's
all the data can also be found on Sam's website.
Thank you. Thank you. We do have a question.
That's not a question.
Or a question or a comment. Go ahead.
Thank you, Mr. Chairman. I think I've certainly have listened intently to what we just heard, and I certainly sympathize and empathize with all these stories. But I do want to point out that if some of this stuff happened before last year, we may have had these products, but the Agriculture Department did a wonderful job last time in 24, I believe, with 494, and a lot of the issues with the hemp have been addressed. You have to be 21 now to buy it. The packaging has changed. You have to have a COA barcode, and so you know what's in the product. A lot of the issues with overdoses and those synthetic products have come in gas stations, that products have been delivered from China, laced with other things. God knows what was in them. But our Agriculture Department is doing the best they can. And they have, I think, some more enforcement people come on board. And I know they've got a very aggressive enforcement program to try to get these illegal products away from the public. And they should be commended for that. As far as the marijuana discussion, all of those issues were illegal products. And I think it's important that we can separate our legal product regulation in Georgia from the illegal products. That I notice we got some law enforcement back here, and I know they have their hands full taking care of that. But I just want to make that statement, so we clarify that.
Thank you, sir. Representative Ridley.
I have one other comment. With yourself and the others who spoke before you, you all talked about how the statistics from going illegal to legal, or the more ER visits, things like that. But it would be interesting to see how that still compares to things that are already legal, like alcohol or tobacco or opioids. Because when you say, well, it went up from being illegal to legal 178%, but then when you do a Google search and it says it's still less than 1% of ER visits, it's not. So it's just would like to see some clarification there.
Yeah, I actually, and I can provide you with the data, but what we've seen so far, and like I stated, the addition of these medical marijuana laws have not helped with these issues. It hasn't caused opioid use to go down. And I understand that the opioid crisis is a very serious problem, but if one of your taillights is broken, you don't break the other one. You know, there's no reason to.
More like one of the statements you said is when you have a smoke shop, you have 85 more break-ins a year.
Yes.
But like, what about a liquor store? How many more break-ins does a liquor store have in its community? Or, you know, a tobacco outlet. So I'm just trying to compare it to things that are already legal. So you can say, hey, you know, it's worse than what's already out there, or actually it's not. So we can compare to what's already legal and socially acceptable. Does that make sense?
Yeah, I understand. So you're saying if alcohol is just as bad, why does it matter? Or
No, like if alcohol, like you're saying, you know, you have a smoke shop that sells a THC product, you have 85 more break-ins a year. How does that compare to a liquor store? You know,
Okay.
the liquor store is legal and socially acceptable, and be like, well, it's actually 3 times as bad for the community as a liquor store is, which is legal, and this is an illegal product, or things like that, to have a comparison to something that is a known standard across the country.
yeah, and once again, I'm happy to get you that data. And I think comparatively, right, these are substances that are these are drugs that are misused. But I will say there is ample amounts of evidence, like I pulled, that it doesn't matter. Like, and I can get you that data for sure. But if you place a marijuana dispensary in a neighborhood like we saw in Colorado, crimes do go up. I don't have off the top of my head what happens if you put a liquor store. But I don't see a reason to put a marijuana store there just to test or to see, like, because we're going to see an increase either way.
Representative Clark.
Thank you, Chairman. I was going to say, I know you mentioned opioid usage does not go down, but I know in Utah, when they passed medical marijuana, they saw just, there was two things. One, they had 186 patients who had chronic pain, and they saw an 84.4% drop in opioid usage. But also the state of Utah saw a 53% across the board drop in opioid usage. So, I mean, I do believe it drops. And I mean, and also just one of the things to mention, you mentioned veterans and all that. You know, I've served in the Green Berets. I've been in combat. I had a bunch of buddies who've been in service. Thank you. And I know for a fact, and I know these guys very well, going on the medical marijuana, and I'm not saying it fixes everything, but I know it's helped those who had severe injuries have pain for the rest of their lives, and it's helped come off opioids using that. And I've seen it also with the PTSD. And I'm not saying it fixes every person. Medical marijuana is the absolute fix to all, but I have seen it directly. So I think we need to have an open mind. I think we can do a figure 8 with any data and all that to fit our narrative, but I think we have to have an open mind, and I have that. And I think we have to continue to discuss, because I have seen it directly save buddies' lives. So I may have to disagree a little bit on how you frame some of those points.
Certainly.
Can I answer, or is that?
We're going to need to wrap up. I'm going to let a couple of members of the committee wrap us up here. Representative Williams.
Thank you, Mr. Chairman. Thank you for today. I think you've done a wonderful job. This is a compelling issue. There are a lot of thoughts on, and I do think that it showed today, based on what Representative Clark and Representative Ridley said, I would certainly be open to hearing some of the pros that didn't get an opportunity, those that are for, that didn't get an opportunity to testify today. I didn't have that plan, but thank you.
We're used to that. Come on. Okay. Ms. Russell.
Thank you. I just have one question. I was trying to jot down in my mind as you were talking about some of the Delta 8 products, but I have kind of a similar question that I asked previously. When you say Delta 8, do you mean specifically that, or is that more of an umbrella term? Because I know that oftentimes things are marketed as Delta 8, but they're actually other cannabinoids. And so I'm just curious to any kind of data that we can get. You know, I just kind of, everything that we hear, I kind of want to know, maybe I'm being a nerd, but I kind of want to know specifically like what we can tie that to.
Yeah, of course. You know, I think with the 2018 Farm Bill, like I mentioned, there was an increase. And, you know, they name it different things, but Delta 8 THC was what I was referring to specifically in this data, which is, you know, I mean, there's Delta 7, there's Delta 6, I'm sure. Every day there's a new one, but I was specifically referencing Delta 8.
Thank you.
And one last thing, Dr. Fowler.
Hi, thank you. I would like to hear you expand a little bit on the opiate statements that you made. When we look at across the United States, which
Representative Clark brought up Utah, but we see a national fall of 16 to 19% in opiate prescriptions in a state once it's converted to, or starts a credible medical cannabis program. Are you talking about opiate prescriptions filled, or are you talking about illegal opiates? Because that's kind of a broad statement that I'd like some clarification on.
And so overall, and I'm happy to share this data with you afterwards, but overall, the data, from what I've seen, has shown the medical marijuana laws have not reduced opioid use disorder, or has it stopped the usage of prescribed opioids to patients now?
We'll see if we can get some data on all this. I know there's a lot of
Happy
anecdotal
to.
data, but
I'm very happy to.
let's do look. I know Colorado and some other states that are not necessarily in a direction Georgia may be going, but at the same time, sometimes those may be helpful. But thank you for being here with us today.
Thank you guys. Thank you all so much. Thank you, Chairman Newton.
We do have a list. We had 12 spots on it, so we're probably going to hold it to that. I do want to let everybody that wanted to come for public comment, we're probably going to limit you to 2 minutes today. I know some of the stories can't be told in 2 minutes. That's why we have 3 more meetings, including another one back here in Atlanta before we're done in October, November. So if you would like to still speak, I'm going to go down the list. If you still think you can do it in 2 minutes with our yellow and red cards, then please do. And if not, we're welcome to have you either in Augusta next month or back in Atlanta later this fall. So I'm going to start with Dave Rodla. Sorry, sir. Thank you. Please briefly introduce yourself, and please watch the yellow and red 1 minute warning, and time's up.
Okay. I'll make it very brief, I promise.
Thank you, sir.
So my name's Dave Rodabaugh. Some of you might know me from unsuccessful run at agriculture commissioner in the last election. Tyler whipped me there, and good for him.
All right, you're done.
That's right. If I couldn't do that, I can't do this, right? So I am going to take the other side of this argument here, and I have deep understanding.
We've heard 3 sides already. Which is the other side?
The right side.
Okay, go ahead.
I have deep compassion for all the people who spoke because of their traumatic experiences in their families. I'm sure that if we focus just on that, it would be a terrible day. But I also want to say that comparatively to other things like alcohol and prescription drugs and those things, the numbers are minuscule in what we're talking about here. So let's put that in context. So what I want to say is I'm here to make the committee's life easy. I've actually have completed the Georgia Cannabis Freedom Act. And I prepared this and it's available for everyone here. It is what we should be looking at because it represents full plant, whole plant legalization. It encompasses the medical marijuana business. It encompasses adult use, but it also encompasses all the agricultural benefits that this plant can bring to us and our ecology. Just to finish, as far as the numbers go, when we look at this as a whole plant, full plant legalization, and by the way, I do believe it's coming because we the people say it is coming. According to the Atlanta JC Journal, it says that the majority of the people want some form of legalization done. So again, my suggestion and his hope is the committee, we do it properly. We do it as whole plant, full plant, realize the entire benefits because legislation has not stopped anybody from smoking pot, okay? No legislation you get will stop people from smoking pot. So my suggestion is for you, the people that we want representing us, let's bring about sensible cannabis legislation that benefits all of Georgians. Thank you for your time.
Thank you for your testimony. Mike Griffin. Once again, if anybody wants to pass or doesn't answer because you can't do our 2 minute, I certainly understand, and we'll give you more time at the next meeting. Go ahead. Yes, sir.
Thank you, Mr. Chairman. I am Mike Griffin. I'm the Public Affairs Representative of the Georgia Baptist Mission Board, and that we do represent up to 1.4 million Georgians, approximately 3,400 churches in our state. I've been down here 18 years and 12 years with Georgia Baptist and dealing with social moral issues. And Georgia Baptists wholeheartedly support Georgians for responsible marijuana policy. We really do appreciate the Executive Director, Michael Mumper. We also appreciate Dr. Greg Raduca. We've worked together and known each other for a number of years. We did support Senate Bill 33, which was sponsored by Senator Kay Kirkpatrick. Also, Senate Bill 245, sponsored by Senator Bill Cowsert. I did have an opportunity to testify on Senate Bill 254. And I do want you to know that Georgia Baptists are in favor of greater restrictions on the use of hemp products. And one of our greatest evidences of loving God and loving your neighbor is caring about public health and safety. And while it is true that we may disagree on uses of certain substances, we must all agree that protecting others from negative outcomes is very important. So we believe that Georgia should limit the total amount of THC and other intoxicating cannabinoids in consumable hemp products is so very important. And also just a general rule that I've used on different social moral issues and different types of substances is that availability does equal sales, sales does equal consumption, and consumption can equal potential problems. So we do need to regulate that and be very careful on that. And we do need to realize, again, as I said yesterday in the gambling hearing, Romans 13:4 talks about the fact that government is to be a minister of God to the citizens for good, not evil. And so I thank you, Mr. Chairman, and your whole committee that you're interested in seeing what you can do to help in public health and safety on this issue. Thank you very much for the time.
Thank you for being here today.
Yes, sir.
Joe Rossetti. Are you here? Raise your hand if you're here. Did I say it right? GRMP advisor. So is that a Sue? I apologize. Come on up, ma'am. Come on up. Oh. We'll come around and get it. Thank you. You go ahead to the podium. It's a Sue. Thank you, Sue.
Sorry.
Rosette.
Okay, so I am so glad you.
We do have our
doctor.
brief 2-minute warning coming up, so thank you.
And I'm going to make it very short. Thank you for the opportunity to testify. My name is Sue Rushi. I ran National Families in Action for 46 years and wrote the weekly e-newsletter, The Marijuana Report, covering all the research for NIFIA's last decade. Based on what I learned, I've just published a book called Marketing Pleasure: How Addictive Drug Industries Tell Big Lies to Make Big Profits. It's available on Amazon, and I hope the committee will read it. The U.S. Food and Drug Administration is responsible for approving all medications in the United States. And FDA has sent 2 warning letters to CBD stores in Georgia. Federal agencies enforce, both are cited for selling unapproved human and animal drugs, misbranded drugs, and adulterated food products with unsafe additives that can endanger public health. I would ask you all to go, and there's a list of CBD stores in my testimony. I would ask you all to go and visit a CBD store or a vape shop or any place, a convenience store that is selling Delta 8. Take your doctor with you. You don't have to do that. And go incognito and ask questions and ask your doctor afterwards what he is saying about what the clerks and the bud tenders tell you. Thank you.
Thank you for your concise testimony, and we will get this out to the committee with the locations. Thank you, ma'am. That would be even better. Thank you. Greg Raduca, Dr. Raduca, are you still here? And do you think you can hit this 2-minute target? Thank you for being here today. There you go.
Thank you, Mr. Chairman. Thank you, committee members, for still being here after all this time. I greatly appreciate that. And for me, and Chairman Newton has pointed to this, perhaps indirectly with some of his questions regarding THC variations other than Delta 9. For me, it's a little bit like being in the twilight zone, because all the regulations we've talked about, SB 494, it all has to do with one type of THC, and that is Delta 9. And that's great. And a lot of work has been done, as has been noted, on regulating Delta 9. making it unlawful over 0.3%. Wonderful. However, the fact is, as some of the testimony, including our young student, mentioned, the Delta loophole is legal. So we have legal products. A Georgia gummy can be 0.3% Delta 9, great. It can also be 95% Delta 8 or Delta 10 or THCP. And as Director Russell was saying, the cannabinoid picture is much more complex than just Delta 8. It's also more complex than just THC, but I won't go into that right now. But THCP, for example, which was in a jar of gummies that I was able to purchase.
Just in case I didn't say it, the next committee meeting is August 21st, and the other dates I will list in the comments below. Anything you want to say, Tiger Lily? You want to say? What do you want to say? What? Come here. She's very talkative. This little Bengal mix creature. She's got a lot to say about biscuits.
THCP, for example, which was in a jar of gummies that I was able to purchase in Roswell, is around five times stronger than Delta 9 THC. So incredible amount of work to be done to please pass a law to close the Delta loophole in Georgia like 20 other states have done. The only thing about, I'm going to say about medical marijuana, and I've been in the field for about 50 years, lobbying for about 10, is that the age ranges, the connection with children is not only a connection with children, but it's also with toddlers and possibly infants. The testimony that I've heard over the last 10 years is some parents are giving their babies and their toddlers and their very young children unstandardized doses for unstandardized duration of THC. If we go to 50% THC, what is that going to do to a baby's brain? You know, we've been talking about brain development up till 24, 25, the babies, young children. So please look at some age minimums for 14 of the 17 conditions whose age minimum is currently at 0 for medical marijuana. That would be wonderful.
Thank you for your presentation today. I know those are some tragic conditions that are being treated and are attempting to be treated, but thank you for sharing with us. I know we do have in our packets for the committee a letter, I believe, written by you. So we'll have that for reference to review as well. Thank you, sir. Lowe, Miss Lowe, LOWE.
She wanted to testify that her 12-year-old, her daughter was supposed to die at 12 years old, but she started giving her cannabis oil and she's still alive today.
She's coming back to Miss Bennett, Yolanda Bennett. Are you here? If the 2-minute time frame works for you, you're welcome to testify, please, ma'am. Thank you for being here.
Thank you for hiring me, because there hasn't been so many, we haven't really been represented up here. We heard a lot of things about what the harm cannabis does to people. We heard all the so-called statistics of what it did to someone's child. But my question is, what about all of the other patients that have been healed and cured by this plant? What about those patients, those children that we keep hearing about that you all care so much about? What about those kids that have gone from hundreds of seizures per day down to 2 or 3? What about the good things about cannabis? Cannabis saved my life. I have not always been pro-cannabis. I'm a former correctional officer and a truck driver. I grew up in the Reagan era, so yes, it was embedded in my head. But the thing about it is, cannabis was what saved my life. And if it wasn't available, I wouldn't be standing here before you right now. Cannabis allowed me to be weaned off of high-dose steroids. I went through several steroid crises because they were treating my condition with pharmaceuticals. The only thing that weaned me off of those 40 milligrams a day, you were talking about 40 milligrams a day, you know how much steroids could harm your body. Right now, I have Cushing's syndrome for this. Not knowing what's going to happen to me in the future, but I just know that you don't want to have to need this. But just in case you do, I hope it's available for you. So my heart goes out to the ones who are unable to manage through that. But out of all of the cannabis misuse disorders, did they mention the 90% that did not go through that? They keep talking about the bad. There's more good than bad. Thank you.
Thank you for your testimony today. Angela Watson. Ms. Watson here? Oh, okay. Weston, did I say that right?
It's
Weston. Thank you, Ms. Weston, for being here today.
Thank you. Hello, my name is Angela Weston. I am the co-founder and director of education of the Georgia Medical Cannabis Society. Good afternoon to all the committee members. I want to begin first by stating that I'm disappointed because I don't see a number of patients or advocates who are part of the committee. It's deeply concerning to me. How can we have meaningful conversations about medical cannabis without the very people these policies are meant to serve? Patients should not only be invited to testify, we should be involved in every step of the process. When we're in the room, we can answer your questions and provide critical real-time input. We are the ones that live this experience every day. As a patient and someone who went back to school to earn a master's in medical cannabis science and therapeutics, I can tell you, Georgia's current program is not enough. We need full access to the plan, including inhalable forms. For someone like me, who lives with chronic neuropathic pain and anxiety, a few quick puffs can bring relief in minutes. Waiting 30 minutes to an hour for a tincture to kick in is not an option when we have daily lives that we need to continue to live. We also need to provide patient education. THC and CBD are not the only cannabinoids in this plant, and a lot of people don't know that, including providers. So we definitely need to have education. And one thing that I'm going to close out saying this, the Georgia Medical Cannabis Society this past weekend held a holistic health and wellness summit. I wish some of you could have been there because we had experts from across the country who came and talked about cannabis, talked about how it's used and how we need to be able to use it for patients. So in closing, I would like to say that what's missing from our current policy is the conversation directly with patients. We need the insight from those who live with the consequences of limited access and lack of education. I believe this committee has the ability to move Georgia forward, but that can only happen if patients are truly included and not just an afterthought, but part of the process. Thank you.
Thank you for being here. Erin Jimenez.
Hi, thank you for having me. My name is Erin Jimenez and I run my own marketing firm. One of my clients is a cannabis client here in Georgia. I'm here on their behalf, but also on my own behalf.
Medical cannabis.
Not medical cannabis, hemp cannabis.
Sorry.
Yes.
Hemp. Okay.
Sorry about that.
Thank you.
So I guess I'll keep it brief because that's what the goal is. 494 tackled a lot of regulatory concerns we had with hemp in Georgia. It tackled packaging, it tackled age, it tackled a lot of things that our industry would argue that it shouldn't have tackled. Even like changing the restriction to total THC. So including that THCA in that limitation. That put a big restriction on products that we were able to carry, as well as the flower ban. So what have our customers done?
Has that gone into effect already?
It has.
Okay,
Yes,
thank you.
it went into effect in October.
Okay.
That has taken a huge toll on the business that I represent. It also took a toll on the customers that I deal with on a daily basis. They have had to pivot to other forms because even if trying a gummy was an option, that doesn't do it for some people. Some people are ediblocked. They can't experience the relief that they need from gummies. There are also concerns with the medical program, which is why they didn't sign up for it. Concerns specifically with cost barriers, concerns with talking to doctors about it, concerns with Second Amendment rights. I hear a lot of different concerns from customers about the medical program, which is why they stick with hemp. They have traveled out of state to get it. They have gone to the illegal market. They have pivoted to other cannabinoids that we don't know as much about, like THCP. So we are told that capitalism breeds innovation. It does. And when you take away Delta-9 THC or limit it in the way that 494 did, they are pivoting to innovative cannabinoids that we don't know as much about. So all that said, to Ms. Weston's point, I also use cannabis. THCV specifically is a lesser known cannabinoid to manage symptoms with polycystic ovarian syndrome. It has helped me immensely. I believe that medical and recreational or adult use, rather, it can coexist. But as stated before, there needs to be open minds, and I would really love to have access to the resources that the presenters provide, because I would love to brush up on some of those that were named. So thank you so much.
Thank you for your testimony. Jackie Wigner.
Good afternoon, Chairman and the rest of the committee. My name is Jackie Wigder, and I stand here today as both a student of medical cannabis from the University of Maryland and the country's only medical cannabis science and therapeutic program. I also stand here today as a patient. A year ago, back in March, I suffered a tragic injury and I broke my neck very severely. I almost ended up paralyzed and went misdiagnosed for 5 weeks thanks to Georgia's medical program. I ended up traveling to New Jersey, my home state where I used to live, for surgery, and worked with my doctor there, my surgeon, with medical cannabis. And because of it, I was able to get off the Valium and Percocet 8 days after a severe spinal surgery. 8 days. So when we are talking about opioid use, I was off, let me repeat, I was off of Percocet and Valium 8 days after having my neck sliced open, my C6 pushed back into place after 5 weeks of it healing in a misaligned position, and then sewed back up. Medical cannabis has saved my life. It has allowed me to stand here in front of you today. But unfortunately, when I came back to Georgia after my surgery, I was faced with a very difficult choice. I either had to risk opioid addiction and continue taking the medicine that I was prescribed, or I could rely on the therapeutically insufficient products here in Georgia, because there are studies. There is a 2023 study that shows that low THC is not sufficient in controlling PTSD and intractable pain, which are the two main conditions that we are treating here in Georgia with medical cannabis. And the final choice is to commit a crime and cross state lines and get my medicine from another state where medical cannabis has sufficient dosing product availability. So today, Chairman, I ask you to remember the oath that you took as a physician to first do no harm. Because the current medical cannabis program is actively causing harm to patients like myself who can't get medicine here and who are even worse off than I am and have to rely on those other things. So yes, cannabis is a powerful medicine. It is not without risk. But whenever we talk about risk, compared to what? Alcohol has many more deaths and is far more dangerous, and we are not having these conversations. Opiates has caused many deaths, and it is still prescribed. Why? Because of a risk-benefit analysis. We need that same approach with medical cannabis. So committee members, Chairman Newton, please remember your oath to first do no harm and take an evidence-based look at the regulations and legislations that you are putting forward, and please rely on experts like those at the University of Maryland and myself that are going to school specifically to get trained and educated on the difference between Delta 8 and Delta 9 and Delta 10. There is no Delta 6. So thank you very much for your time today. And I hope that you take everything that we're talking about into consideration and get back to that oath of doing no harm. Thank you very much.
Thank you for your work and for your testimony. No, thank you. Aviva?
Hi, Chairman. Thanks for making time for us, everyone, even though we ended at 3. I appreciate you. I really love physics and this astrophysics. Neil deGrasse Tyson, he has that famous quote, the challenge to humanity is to know enough about a topic to think you're right, but not enough to know you're wrong. And this has been a huge upstream battle for those of us who have seen the light and how amazing cannabis is, whether it's for gasoline, fuel for your car, or medicine. And I have to be so grateful for those who suffered so much to keep this plant alive. And I would love us all to take a moment and realize we wouldn't even be having this conversation if people didn't risk getting arrested and maybe even getting killed for treasuring this cannabis plant this whole time, continuing to cultivate and learn from it. And, you know, you can hate cannabis as much as you want. I love it 10 times more. And we can look at those statistics. It's just, we have to also balance it out and look at the experts. All these states have learned so much. Let's bring the experts in for real, not just the expert haters. And as chairman of the appropriations, higher education, let's appropriate some money for some more research. You know, as a member of the veteran committee, let's be aware that federally, they just passed something that had an amendment. I don't have the number off the top of my head, that said legal states only can prescribe to veterans. So in order to honor our veterans, it is our duty to be legal. It's our duty to, as a tourist state with FIFA about to come here, how much tax money can we appropriate to the billion-dollar road projects that we have sitting on the shelf right now? This is a huge, awesome opportunity, and my time is up.
Thank you for your testimony, and we will move along. Mary Adams.
Thank you, Mr. Chairman.
Welcome.
I'm here as a representative of about 3,000 Georgia patients, as well as a patient myself. I own a medical cannabis doctor's clinic. I came as a representative from Florida, where I was very active. And I would just like to encourage each of you to take some time and give those of us that have education, that have 10 years experience in this field, we would love to spend 15, 20, 30 minutes, an hour with you, educating you, letting you speak to our patients, and letting you know what is good about the program and where the program is failing the 33,000 patients that we have. I talk to 20 or more patients a day, and sometimes it's heartbreaking, and it actually kicks in my PTSD in hearing their stories. So I would encourage you to please separate hemp from the medical cannabis program in the next time you're willing to sit and talk with us, because we spent a lot of time today on Delta 8 and Delta 9, and that has nothing to do with medical cannabis. And we really, really, really deserve a chance to let you know what's on our patients' minds, how they feel about the program, and to help you honor your oath to give them a program that would work for them. They are depending on you, and so am I. Thank you.
Thank you for your testimony. And the last person on the 12 spots we had is Suzanne Swain.
Hey. That was the last one. Hi, my name is Suzanne Swain. I'm here just as a citizen. A lot of voices speaking into this, which I'm really glad. I'm really thankful for the questions you're asking. So I've been following this issue since 2015, and Representative Powell's not here, but that process was very interesting to see, kind of a backwards process in a way. So what I'd like to just summarize by saying this: it's an intoxicating substance. It is, whether it's Delta 8, whether it's medical, whether it's hemp derived, it's intoxicating. We're talking about levels, we're talking about accessibility. And for Georgia, this is a new industry. That's the other thing you have to consider. So your job here, first of all, I'm sure most of you, there's a lot of confusion even between speakers, between you all. So I urge you to take the time to get as educated as possible. So when it's time to make recommendations for policy, that you'll continue to use our Georgia motto, justice, wisdom, and moderation, because lives are at stake, youth well-being is at stake, and we want to keep these communities strong because we're proud to be Georgians. So thank you for serving and using that wisdom.
Thank you, Ms. Swain. Thank you very much for that testimony. That was the 12 spots that we had. We do have others that signed up on the back in various places, but we do need to conclude this particular meeting, knowing that we do have 3 others, including another one in Atlanta if transportation is a challenge. The next one will be in Augusta, August 21st. I want to thank the committee for your participation and your questions and your giving the thought that's needed to it. I do think that was a nice summary at the end. Thank you, Ms. Swain, for that. Thank you to the committee. And with that, I'll agree with that. And we will adjourn today's meeting. Thank you.
We've reached the end of the video. You made it. Congratulations. Give me 5. All right, stay tuned for the news clips from the day. Would love to hear your comments about that. Have a beautiful day. Thank you for supporting this channel. Please watch some more videos and stay educated. Take care, and thank you again for liking and subscribing and commenting, and see you in the next one. You got to save to survive.